our esteemed speakers, experts, and all the attendees for being here today. We would also like to thank our sponsors, organizers, and most importantly to each of you for being here.
Now, without further delay, I request Dr. Bhupendra Basnet, the Vice Chancellor of National Academy of Medical Sciences, for his welcome remarks.
Namaste, good morning. यहाँ उपस्थित मेरा आदरणीय सिनियर सरहरू, उपस्थित सम्पूर्ण कलिग्स, इन्टरनेशनल डेलिगेट, नेशनल डेलिगेट, सम्पूर्ण उपस्थित साथीहरू, सर्वप्रथम त यहाँहरूलाई म ग्यास्ट्रो अपडेट 2025 मा स्वागत गर्न चाहन्छु। अलिकति यसको ब्याकग्राउन्डमा जाने हो भने कसरी सुरु भयो यो भन्ने कुरालाई अलिकति यहाँ भन्न उपयुक्त होला जस्तो लाग्यो। वीर अस्पताल र टिचिङ अस्पतालमा जुन बेला डीएम प्रोग्राम सुरु भइसकेको थियो, त्यसमा केही एकाडेमिक कुराहरूको कमी थियो। त्यो एकाडेमिक्सलाई वीर अस्पतालले सर गंगाराम अस्पतालसँग कोल्याबोरेटरले दिल्लीको हस्पिटल सँग कोल्याबोरेट गरेका थियो, नाम बिर्से। हामीले त्यसलाई एकाडेमिक प्रमोट गर्ने भनेर लागेका थियौँ। हाम्रो सरहरू यहाँ उपस्थित हुनुहुन्छ जसले डीएम प्रोग्राम सुरु गरे नेपालमा। त्यो पछि ग्यास्ट्रोइन्टरोलोजीको फिल्डमा निकै नै फड्को मारेको छ नै, र त्यो एकाडेमिकलाई मोर एकाडेमिक बनाउन यो ग्यास्ट्रो अपडेटले निकै भूमिका खेलेको छ। जतिखेर वीर अस्पतालमा डाक्टर विधान हेड अफ डिपार्टमेन्ट हुनुहुन्थ्यो 2017 मा, त्यो बेला म अस्पताल डाइरेक्टर थिएँ। हामीले ग्यास्ट्रो अपडेट गरौँ भनेर वीर अस्पताल र टिचिङ हस्पिटलको कम्बाइन्ड इफोर्टमा होटल हिमालयनमा यो प्रोग्राम सुरु गरेका थियौँ। अहिले यो एउटा हाम्रो एकाडेमिक वार्षिक क्यालेन्डर इभेन्ट भएको छ। हामी हरेक वर्ष, एक वर्ष वीर अस्पतालले, एक वर्ष टिचिङ अस्पतालले यो एकाडेमिक इभेन्ट गरेका छौँ, र योचोटि डाक्टर मुकेशले निकै मेहनत गरेका छ कि यसलाई मोर इन्टरभेन्सनल ग्यास्ट्रोइन्टरोलोजीमा फोकस गरौँ भनेर, र हामी सबैजनाको सहभागिता यसको लागि निकै महत्त्वपूर्ण रहनेछ। र एकाडेमिक डेभलपमेन्टमा अहिले एज अ होल इन फिल्ड अफ मेडिकल एजुकेसन नेपालमा धेरै नै प्रोग्रेस भएको छ, र ग्यास्ट्रोइन्टरोलोजीमा त निकै नै प्रोग्रेस भएको छ। त्यसैले यसमा केही छुटाउनै नहुने नाम मलाई लाग्छ। जसले ग्यास्ट्रोइन्टरोलोजीको एकदमै जग बसाल्नु भयो। आज यहाँ हामी बीच हुनुहुन्न प्रोफेसर आइएल आचार्य। जसरी डीएम प्रोग्राम सुरु भयो त्यतिखेर डिन हुनुहुन्थ्यो, अहिले पनि हुनुहुन्छ डाक्टर सीताराम चौधरी। उहाँलाई पनि हामी एकदमै स्वागत गर्न चाहन्छौँ। र खास गरी यो डीएम प्रोग्राम पछिको टाइममा ग्यास्ट्रोइन्टरोलोजीको नेपालमा थुप्रै ग्यास्ट्रोइन्टरोलोजिस्टहरू बन्नुभयो। अहिले सर्भिसको हिसाबले पनि नेपालमा राम्रो भएको छ, एकाडेमिकको हिसाबले पनि राम्रो भएको छ, र हरेक एकाडेमिक एक्टिभिटीमा यहाँहरूको सबैको पार्टिसिपेसन पनि एकदमै धेरै नै छ। र म के भन्न चाहन्छु भने जुन बेला यो प्रोग्राम सुरु भयो, प्रोफेसर डाक्टर दिनेश श्रेष्ठ, प्रोफेसर शशि शर्मा हुनुहुन्छ यहाँ, उहाँहरूलाई एकचोटि उठेर यहाँहरूले ताली बजाएर स्वागत गरिदिनुहोस्, जसले हाम्रो यो बाटो अगाडि बढाउनलाई सहयोग गर्नुभयो, हामीलाई बाटो देखाउनु भयो। स्वागत छ सरहरूलाई। र अन्त्यमा डाक्टर फिलिप म्याथ्यू, he came from India for this program as a guest speaker. I like to welcome him. I like to welcome all of you here, and I wish all the success of this program and active participation. Thank you everyone.
Thank you, sir, for your welcome remarks. Now we request the former head of medical and surgical gastroenterology, Professor Dr. Dinesh Shrestha, Dr. Subodh Adhikari, Dr. Shashi Sharma, and Dr. Bidanidhi Paudel to formally inaugurate the session by lighting the panels. Thank you, sir. Now we would like to request all of the attendees to stand up in their respective seats for the national anthem.
थुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली सायो थुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचला वीरहरूका राजधानी स्वतन्त्र ज्ञान भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
Now we begin with the very first session of today's event, that is the endoscopic session. I request the chairpersons, Dr. Sanjay Paudel, Dr. Dipesh Gurubacharya, Dr. Amit Man Joshi, Dr. Ajay Gautam to chair the session.
Good morning, respected teachers and everyone. It's my pleasure to announce first presenter of the day, Dr. Bikram Pradhan, who is one of the finest gastroenterologists of the town. Please welcome him.
Because of some technical, good morning everybody, and sorry for this delay because of some technical problems. First of all, I would like to thank this organizing committee for inviting me to this wonderful update, and also for making me the opening batsman of this session. Kya? आएन क्या स्लाइड स्लाइड आएन क्या आएन त यहाँ त्यहाँ आएन नि त ए ओके sorry once again. Now we'll start our session, and thanks once again to the organizing committee for inviting me and making me this opening batsman. So we'll be talking about the topic of the benign management of the benign esophageal strictures. So I'll be talking on a little bit about etiology, the clinical and endoscopic assessments of the stricture, different endoscopic modalities of treatment, and finally in few words on the refractory cases. So regarding the etiology, as we all know that the peptic strictures are the most common cause of benign esophageal strictures. Now, because of the use of PPIs, large extent this has been decreasing. The second most common, probably in our setting, is the corrosive stricture. And this corrosive stricture can sometimes lead to very refractory cases, refractory to multiple dilatations. Eosinophilic esophagitis is another cause which is underdiagnosed and probably is the second most common benign disease of the esophagus. The issue with esophageal esophagitis is that the longer you take to diagnose the disease, the more is the prevalence of this stricture. Then there are some iatrogenic causes, as we all know, the post-RFA, post-EMR, ESD in the esophageal lesions, then post-radiotherapy, anastomotic stricture. So these are the different benign causes. So what do we do when you come with this, deal with this type of strictures? As with all diseases, first and foremost is the clinical assessment. You need to assess clinically what is the underlying cause. Probably most of the cases, when you see that you blame it on peptic strictures, but this might be related to some drug-induced. So it's very important to take a drug history, and severity of dysphagia assessment is again important, because you need to grade the dysphagia according to some scores. I've given a dysphagia score where you can grade it. You have to objectively assess the dysphagia so that you know what your intervention or how your intervention has helped. And finally, nutritional assessment is important to know the timing of the intervention. You know when to time the intervention. So I've divided the management in three broad headings: pre-dilatation intervention, dilatation procedure itself, and the aftercare. So most of the patient of the stricture requires some form of dilatation. So what do you do in pre-dilatation intervention? You do an upper GI endoscopy and try to assess the stricture. You try to define the length of the stricture, the type of the stricture, the complexity of the stricture, right? Then look for the presence of ulcerations and rings. And it is always advisable to do a biopsy in all cases. Though this may delay the intervention for a few days, it is very important to do the biopsy of the stricture in all cases to rule out malignancies and also rule out the eosinophilic esophagitis, which is quite prevalent disease nowadays. And you also do a barium swallow if you suspect that there is a complex stricture where you cannot assess the length of the stricture by doing endoscopy. Then the dilatation procedure. You can do it through the scope balloon. Different types of CRE balloons are available of different sizes, right, starting from 6 mm to 20 mm. Then you can do bougie dilatation. You can do it without fluoroscopic control in simple stricture, but complex stricture is better to do dilatation under a fluoroscopic guidance. Finally, the aftercare follow-up. You have to look for the complications. especially perforation, and this patient needs to be on PPI, PPI, high dose PPI for long term to prevent acid-related injury in the post-dilated esophagus. So how do you estimate the diameter of the stricture? You can have a rough estimate of the diameter of the stricture by doing endoscopy itself. The endoscope which we use, the normal one, has an insertion tube diameter of 9.8 mm. So if you can pass the scope, probably it is 10 mm or more. If you cannot pass the scope, but you can a pediatric scope, it is 5 to 10 mm. If you cannot pass the pediatric scope also, it is 2 to 5 mm. And if you can pass or cannot pass or can pass with very difficulty, the outer sheet of a needle knife catheter, it is less than 2 mm. So this is how we endoscopically, assess the diameter of the stricture. And then you have to divide it into simple and complex stricture. Simple are those which are short strictures, less than 2 mm. If it's straight, it's more than 12 mm in diameter, allows the passes of a scope. Whereas the complex strictures are those which are longer strictures, tortuous, and it does not allow the passes of a normal diameter scope. Most of the patients of the stricture will require some form of dilatation, and up to 90% of the stricture can be dilated without recurrence, but there may be recurrence in some cases. So two methods are usually used, the Buzy dilatation and the balloon dilatation. The difference between two is that with balloon dilatation, you have only radial expansion. The radial force is applied, whereas with Buzy, you have both radial as well as longitudinal forces applied in dilatation. Balloon dilatation can be done under direct visualization. So you can also control the dilatation of the balloon. You can see the dilatation process itself. And if you see there is some form of, mucosal tear, you can stop dilatation. Whereas Buzy is blind dilatation. So theoretically, when you theoretically speak, it appears that balloons are safer than the Buzy, because balloons apply only radial pressure, whereas Buzy it has both longitudinal as well as radial. But what does literature say? Are balloons more safer than Buzy? So this was a trial. It's a meta-analysis of 5 randomized control trial, and they compared Buzy with balloon in benign esophageal stricture. As you see, there is no difference in outcome regarding symptomatic relief, recurrence, or even no difference in the adverse effect also. So they concluded that both the Savary-Gilead Buzy dilatation as well as balloon dilatations are equally effective and equally safe in achieving adequate dilatation. The choice depends upon the physicians, his expertise, the availability of the accessories, and also the economic consideration, because the Buzy are a little bit cheaper to use than balloons. And this is one method, rendezvous procedure, which is done in case of very tight strictures, especially in post-RT strictures, post-radiotherapy strictures, which is also known as the CAR. This is the combined anterograde and retrograde dilatation, where you dilate the stricture from both ends. You put an endoscope from the stomach, you put another scope from the gastrostomy tube, and have a look at the both sides of the stricture, proximal and the distal. You pass the guide wire to the distal esophagus and catch the guide wire from the proximal esophagus with a biopsy forceps and dilate it. So different case reports are available, and it has been found to be successful in those patients which are not accessible to balloon dilatation by usual method. And there are certain rules of dilatations. One is, the most important one is rule of 3. That is, in one session, you cannot dilate more than 3 mm to prevent the refractory strictures. But this is not a very based on robust data. There are different studies which have shown that if you can dilate to more than 3 mm also, it does not show much of the complications. Then how much to dilate? So there are studies especially on this anastomotic strictures, where they have shown that if you dilate more than 16 mm, the prolongation of dilation-free period is quite higher as compared to when dilated to 16 mm. It probably will apply to other benign strictures also, and the recommendation is to dilate up to more than 15 mm. Of course, there can be some complications. Then there are certain strictures which are refractory to dilatation. The certain strictures which are recurrent strictures. So there are different definitions. As you can see in the picture, I'm not going to read this. So there are some strictures which are refractory to treatment, and there are some strictures which are recurrent. And these are usually seen in anastomotic strictures, corrosive injury strictures, and radiation strictures. These strictures have a high tendency to become refractory. So what are the options for those refractory strictures? One is you dilate and you inject steroid, or you inject mitomycin C inside the stricture itself. The second option is the stricturoplasty, where you incise the stricture endoscopically. The third is the placement of the stent. You can place the fully covered self-expanding metallic stent, or you can also place a lens. Nowadays, there are also biodegradable stents which are coming up. And finally, if everything fails, you have surgery and self-dilatation. So how do you go about with this intralesional steroid injection? A triamcinolone is given, which is available as a 40 milligram per ml solution, diluted with 1 ml of normal saline, and you give 4 quadrant injections of 0.5 aliquots. And this has to be followed by dilatation. And results have shown that there are different RCTs, though we don't have robust data on this, but recently in 2020 in Endoscopy, this article was published, which is a meta-analysis of 3 randomized controlled trial, which showed a very significant beneficial effect of intralesional steroids along with dilatation as compared to placebo with dilatation. The mitomycin C also can be given intralesionally, but these studies are lacking. There are few case reports. Probably you need more RCTs before you can recommend giving mitomycin C as a therapy for refractory strictures. So what is this endoscopic incisional therapy or endoscopic sclerotherapy? It is nothing. You use a needle knife or use an IT knife to incise the stricture. Radially, you incise the stricture in a longitudinal fashion. You give 4 to 8 radial incisions, and usually the IT knife is preferred because it has a ceramic tip which is insulated, and then it helps in preventing perforation. And this is the picture which I have shown. It's a post EIT esophagus, and it was shown to be very effective in this study. So what the study says, the evidence says that this was a study which was published in Gastroenterology Endoscopy in 2012. They compared the patency rate of this endoscopic incisional therapy versus repeated dilatation in anastomotic strictures. And the 6 months and 12 months results, they have shown that the patency rate for endoscopic incisional therapy was significantly higher as compared to repeated dilatation. What about stents? So the stents, different types of stents has been used. This is a meta-analysis using the SEMS, the self-expanding metallic stent, the self-expanding plastic stents, the biodegradable stents. So this was a study, a meta-analysis of 18 studies, and they have showed that the clinical success rate of about 40%. There was no difference in the type of stent used regarding the clinical success, but most common adverse effect was the stent migration, and this can be prevented by some suturing devices to the stent. Though the stenting, the esophageal stenting is very high for the management of malignant dysphagia, the algorithm. For benign strictures, data are limited. It's only used in those cases where the other methods fail, and you cannot keep the stent for more than 12 weeks. It should usually kept for 6 to 8 weeks. And there are recommendations you can fix the stent if there's a history of prior migration of the stent.
Dr. Bikram, can we...
This is the final slide.
Thank you.
Thank you. So this is just, I want to show this is the algorithm of what was talked in the previous slide. Not going details of that. So finally, in conclusion, ladies and gentlemen, this benign esophageal stricture has a significant impact of quality of life, not only because he can't swallow, also because he has to go to multiple times to the hospital setting for dilatation. And for each patient, it has to be an individualized approach because each stricture are different. Dilatation is an important part of algorithm, and both are equally effective and both have equally safe. And a methodical stepwise approach is required for better outcome in patients with benign refractory strictures. Thank you very much.
Thank you for the presentation. We'll have the question and answers at the end of the session. We'd like to call Dr. Robin Hamal, who's going to be speaking about SEMS for esophageal carcinoma.
Good morning and thank you for the invitation. The topic I have been allotted is SEMS for malignant esophageal obstruction, and I declare no conflict of interest. Now, esophageal malignancy can be of exophytic, which is predominantly intramural. It can be stenosing, which is predominantly intramural. Exophytic is intraluminal. Or there can be extrinsic compression, or sometimes there can be tracheoesophageal fistula. Now, self-expanded metal stent, SEMS, is the most favorable option in patients with a poor predicted prognosis because it provides immediate and rapid relief of dysphagia. Now, ideal self-expanding metal stent should be easily introduced. There should be a simple mechanism not requiring dilatation. It should be radio-opaque. It should not ideally shorten on deployment. It should be of narrow dimensions when compressed. It should be either deployable from either proximal or distal end. And it should be removable or partially redeployable. And also it should resist external compression, prevent tumor ingrowth or overgrowth, and not migrate. And also it should be inexpensive. But the ideal self-expanding stent does not exist. What does exist is a metallic stent which is made of nitinol, which is an alloy of nickel and titanium, and it has a shape memory. There is a gradual expansion over 24 to 72 hours as opposed to a plastic stent. It comes in variable lengths and diameters. The release can be proximal or distal. And generally it is deployed over the wire, but some manufacturers provide through the scope SEMS. In terms of covering status, it can be fully covered, partially covered, or uncovered. And depending on the size of the delivery catheter, there may or may not be need for dilatation. Now, the standard SEMS is the one which is placed over the wire. It has a large diameter delivery catheter, about 18 to 20 French. It may be released either proximally or distally. It is widely available and in general use. But some manufacturers also provide through the scope SEMS, which has a small delivery catheter, less than 10 French in size, and it is usually a distal release prosthesis. And it is suitable for very high strictures in the esophagus. Some manufacturers also provide cervical SEMS, which has a smaller diameter and a proximal flange is shorter. So it is useful in the cervical esophagus. Now, these are the SEMS which are currently available in Nepal. The one from Boston Scientific, which is the Wallflex stent, the Hanaru stent, and the NITI stent. And among these, the NITI S from the Taiwan Medical is said to have a low radial force of expansion. Now, we can see that the stent can be either uncovered, which has a very high risk of tumor ingrowth. It can be partially covered, but the flanges are left uncovered so that it embeds in the esophageal tissue. Or the SEMS can be fully covered. The NITI S from the Taiwan Medical also has an anti-migration stent, which has both inner layer, which is covered, and outer layer, which is uncovered. Now, this was a study to see whether partially covered SEMS is better than uncovered SEMS. And although the dysphagia score was similar at 6 months, the reintervention rate was significantly higher in uncovered SEMS because of obstruction due to tumor ingrowth and overgrowth. So nowadays, uncovered SEMS is rarely used in esophageal malignancy. And this was a comparative study between partially covered and fully covered SEMS, which was a little bit older study. It showed that the fully covered stent had a higher rate of migration, and the partially covered stent had tissue overgrowth. So that is why they had less rate of migration compared to fully covered SEMS. But the more recent studies have now shown that there is no significant difference between partially covered and fully covered SEMS in terms of stent migration, in terms of numbers of endoscopic reintervention, or in terms of dysphagia scoring. So fully covered SEMS is one good option for malignant SEMS, especially in those cases with tracheoesophageal fistula. So this was a study to look at high radial force SEMS versus low radial force SEMS, and it was seen that stents with high radial force of expansion had more severe adverse event, particularly in patients who had undergone prior radiotherapy or chemotherapy. So those patients who had undergone prior radiotherapy, it's preferable to use SEMS with low radial force of expansion. So this is another stent which can be placed in cervical esophagus, which has a diameter is less, smaller, and it has the upper flange is also very small. For esophageal SEMS placement in the G junction, there is high risk of reflux, as we all know. So some manufacturers provide SEMS with anti-reflux valve. But in the study, which was shown that although the dysphagia score was less in anti-reflux SEMS, they also suffered more adverse event in the form of migration and obstruction. So there is no superiority of anti-reflux SEMS over conventional SEMS. The mechanism of release, as I said, so some providers, they have anti-reflux SEMS with a valve. Sorry for the interruption. The anti-reflux SEMS, they had improved dysphagia score. However, they had more adverse event in the form of migration and obstruction. So there is no superiority of anti-reflux SEMS over conventional SEMS. And in terms of release, mechanism of release, it can be either proximal release or distal release. The technique of placement of SEMS, it can be done either under fluoroscopic guidance or endoscopic guidance, or in a hybrid approach. So first and foremost, we have to identify the length of stricture, which is of paramount importance before placing a SEMS. And that can be done through fluoroscopy or through a barium esophagram or CT scan. And once you identify the proper stent to be kept, guide wire can be inserted through the stricture, and then delivery catheter over the guide wire if the endoscope cannot be passed through the stricture. And then under fluoroscopic guidance, the distal flange is deployed gradually, and gradually the whole stent is deployed over the stricture, so that the upper and lower flange, they exceed the tumor length by 4 to 6 centimeter. So in this fluoroscopic video, we have deployed the distal flange, and we have also kept 2 radiographic markers on the patient's skin corresponding to the proximal and distal margin of the stricture. And on deployment, the stent tends to foreshorten. So in order to counteract that, you have to provide counter traction. Even though the technical success rate of SEMS is almost more than 90%, but there are some adverse events associated with SEMS deployment that include early and delayed complication like pain or bleeding or perforation. And one of the disadvantages is, or fear is, stent migration or stent malposition. Now for some of the adverse effect like stent overgrowth and ingrowth, we can deploy some methods like thermal ablation or argon plasma coagulation to burn the necrotic part. And sometimes we may have to keep another stent inside the previously deployed stent to relieve the recurrent obstruction. Now, this was a study to see the role of metallic clips in preventing migration, and it showed that, especially in fully covered SEMS, anchoring with 2 or more hemostatic clips prevented stent migration in delayed complication. And similarly, stent fixation with either overstitch device or the over-the-scope clip is better than not fixing the stent, especially when it comes to fully covered esophageal stent. And this is a newly designed over-the-scope clip device to prevent migration of fully covered SEMS, which is now available in our country. Now, prior radiotherapy is a risk factor for adverse event of stenting, as we saw previously. Now, the incidence of adverse events in the most recent studies are lower than that shown in previous studies. And these studies have shown that the use of stent with a low radial force may help to reduce the risk of adverse events. What about radiotherapy after stenting? It is generally believed that there is no additional benefit from concurrent palliative radiotherapy, but it can be offered for a minority of patients clinically considered to be at high risk of tumor bleeding. And however, it has to be kept in mind that additional radiotherapy with a dose more than 40 Gray should be avoided in view of the risk of adverse events. Now, there is no significant difference whether you give chemotherapy after SEMS in palliative setting or not. However, the risk of stent migration is higher in those who undergo chemotherapy, palliative chemotherapy after SEMS implantation. Now, what about stenting malignant stricture before surgery? So, this is a multi-center European study which showed that there was higher risk of mortality, higher risk of morbidity, lower overall survival, less surgical R0 resection, and decreased median time to recurrence in those patients who underwent SEMS placement before surgery. And that is why the ESG guidelines do not recommend SEMS placement as a bridge to surgery or before neoadjuvant chemotherapy, because it is associated with a high incidence of adverse events. So other options such as feeding tube placement are preferable. Now, the other option for palliation of malignant esophagus is brachytherapy. Compared to SEMS, SEMS has a more rapid and immediate relief of dysphagia. However, over longer run, medium to longer run, brachytherapy seems to have less side effect and better dysphagia score. But brachytherapy is not available in most centers. So the algorithm for malignant esophageal stricture, you have to look at the prognostic factors like age and comorbidities, tumor size, and then decide the predicted survival. If the predicted survival of the patient is less than 3 months, then stent placement can be done. Otherwise, if the predicted survival is more than 3 months, brachytherapy or chemoradiotherapy can be considered according to the ESG guidelines. So these are some of the contraindications for SEMS placement. Those terminally ill patients with life expectancy less than 2 to 4 weeks. If there is distal obstruction, in case of perforation, bowel ischemia, sepsis, or uncorrectable coagulopathy, SEMS placement may be contraindicated. Now, previously, esophageal strictures less than 2 centimeters from the upper esophageal sphincter was considered a contraindication, but as we saw previously that there are newer stents which can be placed in the upper esophagus as well, and it is no longer an absolute contraindication. So in terms of future, there are now radioactive SEMS being developed, which has the advantage of SEMS placement as well as brachytherapy, so there is survival advantage. They have shown to have survival advantage and better quality of life, and there is also drug-eluting principles of deployment remain the same. Knowledge of the advantages and disadvantages associated with different designs will aid the endoscopist in selecting the optimal SEMS for a given condition. A randomized study or a prospective study is required to accurately evaluate the efficacy of stenting with other treatment options. Thank you very much for your attention.
Thank you, sir. Dr. Arun Gewali, who is going to talk on endoscopic management of non-varicose UGI bleed.
Bir Gastro. Yes, eh?
So thank you, Chairperson, for the kind introduction. At the outset, I would like to thank the entire organizing committee for providing me this opportunity to present in this wonderful academic session. Today, I am presenting on endoscopic management of non-varicose UGI bleeding. As we all know, the UGI bleeding is bleeding from the proximal GI tract your study. The most common causes of non-varicose UGI bleeding are peptic ulcer disease, portal hypertensive gastropathy, esophagitis, angioectasia, malarious tear, dual-phase lesions, and upper GI tract neoplasms. Being the most common cause peptic ulcer disease, stratified into high risk, intermediate risk, or low risk lesion. Actively bleeding lesions and non-bleeding visible vessels as well as adherent clot, these are the high risk lesions. Oozing from the ulcer is intermediate risk lesion, and flat spots and clean based ulcers are low risk lesions. So as per the Euclacure database, the rebleeding from the actively bleeding lesion is up to 90%. In non-bleeding vessel, it is up to 50%. However, it is insignificant in flat spots and clean based ulcers. So we have various modalities for the endoscopic hemostasis. We have injection therapy, we can use thermal contact probes, and we have various mechanical methods. So for the injection therapy, the most commonly used agent is epinephrine, diluted in 1:10,000 or 20,000 concentration, usually injected into or around the bleeding site or into the stigmata of hemorrhage. The advantage is it is widely available, low cost, safe even in patient with coagulopathy, and there is low risk of perforation. However, disadvantage is it is less effective than other modalities. So we have other sclerosants also, like alcohol and ethanolamine, but rarely used because these are associated with increased tissue damage. So another modality is thermal contact probe. They come in various diameter. Most commonly used are bipolar as well as multipolar electrocoagulation probe, and optimal coagulation occurs in low power setting applied for 8 to 10 seconds, and it can effectively coagulate arteries up to 2 millimeter in diameter. So it works on the principle of coactive thermocoagulation, where the artery is compressed firmly, reducing the heat sink effect, and the two walls
vessels. So what meta-analysis say is application of hemoclip is superior to epinephrine injection, but comparable to thermocoagulation. So what the vessel. So we can inject epinephrine around the lesion to elevate, followed by application of multipolar electrocoagulation. In consensus are APC or hemospray, both are equally effective for the portal hypertensive gastropathy. So next we have is Dewey-Lafayette lesion. It is the abnormal submucosal artery that protrudes through the mucosa, usually located in the stomach along the lesser curve. It can cause massive bleeding. Here in the picture, we can see this beautiful picture of the malarious tear. The most of the bleeding stops spontaneously. Around 90% stops spontaneously. 5% may re-bleed. If there is severe bleeding or if there is re-bleeding, which is not controlled by medical therapy, we have endotherapy with either hemoclips, epinephrine injection, or hemospray or sclerotherapy. And studies, what studies say is coagulation or APC, and both are equally effective. But in Nepal, we usually tend to apply APC, and low risk lesion. If it is high risk lesion, we can have combination of therapies. For the intermediate risk, we have monotherapy is sufficient, and low risk lesion do not require endotherapy. If it is post EMR or post EMR, we can repeat endotherapy, or we can take the help of interventional radiologist, or surgery is always there.
Thank you, Dr. Arun, for the nice presentation. Next, we'll have the question and answers at the end of the session. Thank you. I'd like to call on Dr. Adyasri Karki. We'll be talking about treatment of recurrent Helicobacter pylori infection.
A very good morning to everyone present here. I would like to thank Dr. Mukesh, Dr. Divash, and the organizing committee for giving me this opportunity to speak on this very prestigious platform. The topic for me is management of recurrent H. pylori infection, which as a gastroenterologist we face on a very daily basis, and it's very challenging. So as we all know, Helicobacter pylori is a gram-negative organism which even survives in the harshest acidic environment of the stomach. And it is associated with various things like dyspepsia, peptic ulcer, chronic gastritis. Developing countries and lowest in the developed countries. It has been seen that it infects almost half of the world's population, and in South Asia it is almost 50 to 60%. Who are tested positive for H. pylori should be treated. And treatment is obviously challenging because there are so many regimens that are available, and the cure rate is not 100% by any of the regimen. So selection of the right regimen should be looking at the local antibiotic resistance pattern and also optimum gastric acid suppression. So why is eradication necessary? Because it causes peptic ulcer healing, it can decrease the recurrence of ulcer, it can improve dyspeptic symptoms, and of course it can reduce the risk of gastric cancer. So any acceptable therapy should give a cure rate of at least 90%. And all patients who have been treated with H. pylori should be given a test of cure, that is post-testing eradication test, done after 4 weeks of H. pylori treatment, after stopping PPI for at least 2 weeks, by non-invasive methods like urea bed test or stool antigen test, and by biopsy methods by either RUT or culture. So, as we all know, I'm not going to go into the detail of each regimen, There were various regimens that were used previously for primary treatment, out of which the most common treatment till date, despite the increasing resistance, is triple therapy with clarithromycin. And the secondary rescue regimens were various, like concomitant therapy, levofloxacin-based therapy, and rifabutin triple therapy, out of which I think we all tend to use levofloxacin quite often. So why was there a need for update in the management? Because of the decreasing cure rates worldwide, because of the increasing resistance to certain antibiotics, due to the use of or overuse and misuse of antibiotics that are used for H. pylori, and low compliance to medication because of the high pill burden, high cost, frequent side effects, and of course unavailability of certain drugs in various parts of the world. So this was a study done in India over the past 10 years where the efficacy of standard clarithromycin triple-based therapy was seen. There was seen that over the past 10 years, the cure rate has been decreasing. However, in the study done in 2023, it still showed a ray of hope for clarithromycin-based therapy, where the eradication rate was 93%. This is the ACG guidelines update in November 2024, which has completely changed the regimen for treatment-naive patients, that is, patients who have not received any H. pylori regimen before. So, optimized bismuth-based quadruple therapy is the treatment of choice. Apart from that, alternative regimens are rifabutin-based triple therapy, PCAB, that is potassium competitive acid blockers-based therapies, that is triple or dual therapy, which are all used for 14 days. Why is there a failure of eradication? They are multifactorial, but the most important, as I have told you, is prevalence of antibiotic resistance and incompliance to therapy. So recurrence could be either reinfection or recrudescence. So reinfection, if it is infected by a different strain of bacteria, H. pylori infection, it is called reinfection, whereas recrudescence is when the same bacterial strain is there after a failed therapy. So it has been seen that almost 20% of patients fail initial therapy of H. pylori eradication. So the risk of reinfection is very low, even in the East and West. So antibiotic resistance is increasing worldwide, with US and Europe having more resistance to clarithromycin, levofloxacin, and metronidazole. Even in India, over the past 10 years, we have seen that metronidazole, levofloxacin, and clarithromycin have been having increasing resistance. Nepal is no different. There was only one study that was done, and it showed that clarithromycin, metronidazole, and levofloxacin had the highest rate of resistance, and no resistance to amoxicillin was seen. So in treatment-experienced patients, these are patients who have received treatment of H. pylori even once or twice or thrice. So any regimen that has failed once, then they are known as treatment-experienced patients. So all patients who are treatment-experienced should be treated. Salvage therapy is therapy which is given for any failure of H. pylori with the initial therapy. Low eradication rates in the first-line therapy of less than 85%, the patient should be tested for antibiotic susceptibility testing, and a different empirical regimen should be used than the one that has previously been used. And we should try to use optimized acid suppression with either the higher doses of PPI than with what we regularly use. Even thrice daily dosing of PPI has been used in the newer regimen, and using of more potent PPI like rabiprazole or esomeprazole than other PPIs, and PCAB, that is potassium competitive acid blockers, which are more rapid acid suppressors, and they are more sustained acid suppressors than the PPI which is coming up, like vonoprazan. So this is the regimens that are being used for persistent H. pylori infection since 2024 guideline has been updated, out of which optimized bismuth therapy is the one that is being used. So why is bismuth being used so commonly? Because obviously there is low resistance. When used with other antibiotics, the resistance of other antibiotics like metronidazole, etc. decreases. And of course, various studies done worldwide show that the efficacy is better than any other regimen. So in patients who have already used BK2, what do we use? We have rifabutin-based triple therapy. We have clarithromycin-based therapy, which should be used only when the patients are susceptible to clarithromycin, and PCAB-based clarithromycin triple therapy should be used rather than PPI-based therapy. And another one is high-dose dual therapy, where we use vonoprazan along with PPI or amoxicillin. And this is used because it has fewer side effects and low pill burden, and it should be only used when BQ2 or rifabutin is not available or antibiotic susceptibility test is not available. So levofloxacin-based therapy now should be the last resort of regimen, even though it has good eradication rate, but because of its increasing resistance and because it falls under the black box warning, we should not be using it. Probiotics, there's still a gray area whether we should be using it or not, but it has definitely showed that there is moderate eradication rate and lower risk of side effects like diarrhea when used along with these drugs. Now, what about the scene in Nepal? Just give me one more minute. I'll just wrap up quickly. So, what about Nepal? It's completely different from what the US guidelines have told us, because resistance of clarithromycin, levofloxacin, and metronidazole is definitely increasing. We all know that the prevalence of H. pylori is still on a rise. Antibiotic susceptibility testing is not available. Bismuth, PCAB, and rifabutin is still not available. And the first-line therapy is still clarithromycin-based triple therapy, and the second-line therapy is levofloxacin-based therapy. So, rifabutin, because it should be used with caution, because TB is prevalent in Nepal and it may cause cross-resistance with rifampin. And there are not many studies that have been done in Nepal, so I think it's high time that we start doing studies in Nepal, comparing different regimens and doing a post-test of cure, because we need to know the local resistance, and also we need to understand whether we are actually eradicating H. pylori or not. Future prospects, we need studies comparing these new drugs. There are certain new drugs that are coming up, like furazolidone, garinoxacin, citalfloxacin, rifaximin, nitazoxanide. All these drugs are still being studied because they have low resistance, so maybe these could be helpful in the future. And vaccination for H. pylori, this has been challenging. It has been there for a long time, but it has been challenging because of the immune escape of H. pylori, and also because of the various virulence factor of H. pylori. It has been still studied, but I don't know how far are we on that. So, to summarize, H. pylori is obviously the most common bacterial infection affecting more than half of the world's population, most commonly resulting in gastric carcinoma. So we have to eradicate it in order to prevent progression. Post-treatment testing is necessary. In patients with treatment, experienced patients, optimized BQ2 is the treatment of choice. Use of PCAB over PPI for better eradication rate. And clarithromycin and levofloxacin-based therapy should only be used in patients where sensitivity to the antibiotics is present. So the question at the end is, do we all do post-eradication tests here? How many of us do post-eradication tests? Just one or two. I don't think many of us do that. So I think the takeaway message is, let's all do a post-eradication test and see whether we are actually eradicating H. pylori or not. Thank you very much for your patient hearing.
So thank you, Dr. Adya, for excellent talk on H. pylori. So we would like to invite our last speaker of the session, Dr. Shankar Baral, who is going to talk on gastric pre-malignant conditions.
Thank you, organizing committee, for giving this platform, and good morning, respected all. Oh, okay. Oh, warm greetings from beautiful city of Pokhara. So today my topic is detection and surveillance of gastric pre-malignant conditions. So recently, 10 days back, the American College of Gastroenterology, they published this guideline on the diagnosis and management of gastric pre-malignant. So I'll be updating this guideline also, along with the other. So Dr. Adya recently told that gastric cancer is the leading cause of associated morbidity, and it's most common in the Southeast Asian countries. And the China, Japan, and our neighboring countries are also mostly affected. So gastric adenocarcinoma, till late in the initial stages, they have dyspeptic symptoms, so they get unidentified. So there are various histological stages, just the Dr. Adya told. So they evolve through the different stages. So can we check in between these steps? And as you know, the S. pylori is the most causative pathology. So and type 1 carcinogen. So there are different ill-defined endoscopic images in the initial settings when there is atrophic gastritis or intestinal metaplasia, and we are not using the high definition endoscope. So we might miss these conditions, and we can catch up with the evolved gastric carcinoma. So the basic thing in the prevention of this gastric cancer lies in the detection of the pre-malignant conditions and eradication of S. pylori. So the primary prevention is S. pylori eradication, so we can reduce risks of gastric cancer by 55%. Secondary prevention is early detection of these gastric pre-malignant conditions. So in colon, there is a screening modality is established after 45 years in cases of colon cancer. But in cases of gastric cancer, do we screen all people? But in Korea and Japan, where there is high endemicity, they start screening at the earlier age. And the screening is established. But in cases of other regions, it is controversial. We choose the high risk groups, and this debatable issue is due to the high cost burden, and it is due to the whether there is benefit of screening all or not. So there are two modalities of screening. One is the universal screening. In cases of universal screening like Japan and Korea, where they have high prevalence of gastric cancer and S. pylori, in Japan they have endorsed screening above age of 50 years with UGI endoscopy too early, and in Korea, UGI endoscopy above 40 years too early. So, but in other countries, including rest of the world, the recent American Gastroenterological Association and American College of Gastroenterology, they have advocated that there is beneficial screening in cases of patients with greater than 45 years with high risk features like family history, high recurrent S. pylori infection, and high endemicity and ethnic groups. So let's talk on the rationale of screening. Most gastric pre-malignant conditions start by the age of 45. Before implementation of screening in cases of Japan and Korea, there was less than 30% of the cancers were diagnosed in the early stage, and 5-year survival was only 30%. It was dismal. After starting a screening, they have 50% were detected in the early stage, and overall 5-year survival has increased to 60%. Like in the US, it is a developed country, only 36% of cancers are detected in the stages, in the early stages. So 40% are metastatic, and they are in the era of pre-screening like Japan and Korea. So how to detect these conditions in the early stages? These blood biomarkers like pepsinogen, these are not advocated, that are not recommended. So high quality endoscopy, high definition white light, and image enhancement is the cornerstone of early detection. And neoplastic lesions are mostly missed, around 25%. So proper visualization is the very important. In this picture, we can see the foaming and this pool of fluids. These are obscuring the vision. So if we do adequate insufflation, adequate mucosal cleaning, and spending proper time, this can give the high quality image and the image documentation of at least 6 portions: the greater curvature, lesser curvature, antrum, and incisura, along with the fundus in the retroflexion, and fundus and cardia in the retroflexion has to be documented. So then it comes to the characterization of the visualized images. The normal images, in the normal white light high definition endoscope, you can give the round pit pattern in the corpus, and elongated pit pattern in the antrum. But in the case of atrophic gastritis, there will be pallor, loss of the pit patterns, and there will be visualization of the submucosal vessels. In the intestinal metaplasia, you can give the white opaque substance, and this is light blue crest. In cases of dysplasia, there will be venule, vessel pattern will be deranged. So, though my presentation is not on the image enhancement, but this regular arrangement of the collecting venules and this round pit pattern is seen in the normal corpus. So, this is image enhanced pattern in the corpus. This is in the antrum, elongated pit pattern is seen in the antrum in the NBI image. So, this is the magnified image. And in cases of intestinal metaplasia, which is a precursor lesion, there will be map-like lesions, one white pattern, red pattern, and in cases of magnified NBI image, we can see the light blue crest line. So, if we have these facilities, we have to utilize it and do the proper identification and biopsy. In cases of atrophic gastritis, which is another pre-malignant condition, there are different types like autoimmune atrophic gastritis and environmental atrophic gastritis. So, there are different patterns like I already said visible. This vessel visibility, pallorness, and folds, loss of folds are the corner marks of this atrophic gastritis. So, we have to identify the borders. We have to identify the borders in the atrophic gastritis because 85% of gastric carcinoma occurred on the distal side of the atrophic borders. And most of the cancers that we detect are within the atrophic borders of these lesions. So, identification of these atrophic borders and biopsying from them is very important. So, these Kimamura, Takamoto, they classified the endoscopic atrophy, like the distal atrophy, they have given the low scores, and when they move up along the corpus and the fundus, they give the high scores, like C1 to C3 and O1 to O3. So accordingly, they have risk stratified the atrophic, and this is Kyoto classification for S. pylori. The more these findings, the more the S. pylori inflection. It is a normal white light endoscope. So, we all have this facility. So, it is not an image enhanced endoscope. It is just a white light, high definition endoscope. So, it can be incorporated in our daily practice. So, intestinal metaplasia with these map-like lesions and enlarged folds, nodularity, these are nodularity and diffuse redness. These are highly specific for S. pylori infection and positive predictive value is high. But with these regular collecting venules, if we see like this rules out the presence of S. pylori. So, there are some scores are given in this Kyoto classification. So, if the Kyoto classification is greater than 2 or equal to 2, the S. pylori infection has accuracy, presence of accuracy is 90%. If it is greater than or equal to 4, there is high risk of gastric cancer, and less than 3.8 rules out the S. pylori. So, after visualizing these all conditions, we have to biopsy them properly. So, as you know, the Sydney protocol biopsy, then we take 5 biopsies, but the recent guidelines, what they say is, we have to put the antrum and the incisura in one bottle and the corpus in the another bottle. So, you can see the extension of this metaplasia, and we categorize them in the Olga and Olgim staging system differently, as we know all these histological staging. So, in the histology, what we desire is whether what type of gastric intestinal metaplasia is it, complete or incomplete, and what is the extent in the antrum, corpus, or what is the extension. That helps in the surveillance, because Olga 3 and 4 need surveillance every 3 years. If they have, along with that, if they have family history, they have to screen a bit earlier. So, now moving on the management, if the non-dysplastic gastric pre-malignant condition is found, like gastric intestinal metaplasia, if the condition is high risk means if the histology is incomplete or histology is present in the antrum and corpus both. So, that has to be screened every 3 years. If there is an atrophic gastritis, and it is again a high risk, then we have to screen them every 3 years. Means if the high risk patients are family history from the endemic zones, if they are from the immigrant, and if they have some other risk factors, they have to be screened. Then that was the atrophic gastritis and non-dysplastic conditions. So for the dysplastic conditions, for the low grade dysplasia, if there is some visible lesion, if there is some visible condition, then it has to be resected. If there is non-visible condition, then it has to be repeated after 6 months. In high-grade dysplasia also, if it is visible, you have to resect it. Non-visible, then again do surveillance by 3 months, and after resection also you have to screen yearly. Then another gastric pre-malignant condition is gastric epithelial polyps. Fundicular polyp, they are smooth. Hyperplastic polyps, they have some exudates. Adenomatous polyps, they are velvety, and neuroendocrine can have different shapes and size. So, they are most arise in the case of S. pylori infection. The most common is fungal polyp. Gastric adenomas must have dysplastic foci. Hyperplastic polyp greater than 10 mm might have dysplastic foci. Fungal polyp, unless ulcerated, there is no need to worry. So if there are more than 50 fungal polyps, we have to worry because most use PPI. So they come in the background of PPI infection. So for all gastric epithelial polyps, we have to biopsy the polyp and also the surrounding mucosa because there might be some atrophic and metaplastic changes in the surrounding mucosa. So gastric epithelial polyps is small, completely excised, diminutive biopsy forceps can be used. Larger ones do smear. So this might be the last slide. Fungal polyp resect if it is greater than 10 mm and ulcerated. But if it is there is no other risk factors, leave it. Hyperplastic polyps resect for greater than 10 mm, 5 to 10 mm, it is controversial. Adenomatous polyps resect all polyps 10 mm till 10 mm EMR, greater than 10 to 20 mm EST. Surveillance has to be done. Fungal polyp, no need of surveillance. Adenomatous and hyperplastic greater than 10 mm, surveillance after 1 year. So, conclusion, there are precancerous stages in the gastric cancer development, evolution. So, it has to be catched with good quality image, proper surveillance, proper insufflation, and cleansing. S. pylori eradication, like Dr. Adya said, it is the cornerstone of our management. Screening for all is not advisable in our part of the world right now. High-risk patients, especially greater than 45 years, with family history and endemicity need to be screened. Identification of atrophy, metaplasia, dysplasia, and adequate biopsying from them. Not only doing RUT, rapid urease test, and stool for S. pylori is not adequate in all conditions. That helps in the further surveillance of these conditions. Training on image enhancement is of utmost importance, and follow-up is very important. Thank you.
Thank you, Dr. Shankar, for the wonderful and practical presentation. I think we will not have a Q&A session at this moment. You can ask the speakers about if you have any queries during the tea break. Thank you.
Thank you, all the speakers of this session. Now I request the chairperson to provide a token of love to the speakers of this session. I request all the speakers to come forward, please.
Thank you everyone for this wonderful session. Now proceeding with our next session, that is international speaker session. I request the chairpersons, Dr. Vivek Sharma, Dr. Jivan Thapa, Dr. Sitaram Chaudhary, Dr. Roshan Kafle to chair the session.
very distinguished gastroenterologist in Bhopal, and he is also member of American College of Gastroenterologists. He is a pioneer in poem, and he has participated in many panel discussions. So we have talked from him about endoscopic management of obesity.
Good morning. Thank you for the kind invitation. And at the outset, I would like to thank Dr. Mukesh and the entire team of Bir Hospital for giving me this invitation, and Dr. Sitaram for giving such a kind introduction to me. The topic given to me today in the next 15 minutes is endoscopic therapies for obesity. Before we start with therapies for obesity, we must understand what is the prevalence of obesity. We know obesity is a growing pandemic and with increasing prevalence in India. And you would not understand, this data from the National Family Health Survey shows that it is a massive socioeconomic burden. With 2 billion adults, representing 44% of global adult population, are overweight and obese, and 70% of them residing in low or middle income countries like Southeast Asia or Nepal. What's worrisome is we have a higher prevalence of abdominal obesity. And when we have higher abdominal obesity, we have an independent risk factor for poor prognosis. Not only is obesity harmful in itself, it increases other risks of diseases such as diabetes, hypertension, coronary artery disease, stroke, certain cancers, what else and what not. So we are dealing with a problem that is increasing in prevalence and is causing more problems apart from its own problem. So now we have an epidemic of obesity, diabetes, and fatty liver. These are 3 chronic diseases with a common theme of being poorly managed and are increasing in prevalence. So what are the treatment options for such a recalcitrant disease? We start with the treatment option as lifestyle and diet medications, but when we can go on to surgical procedures. But still there is an unmet need. Why? The unmet need arises from the fact that even those who are actually eligible for surgery, only 1% of them receive surgery, and less than 1% of them who are eligible for medication actually receive medication. So why do they not do that? Because they have a perceived fear of problems. So ideal treatment of obesity should be organ sparing, should be safe and effective, should cause minimal disruption of anatomy, and should not have any long-term consequences. And endoscopic treatment fills this unmet need that we have in management of obesity presently. So the endoscopic treatment options for obesity are 2 types. One that focus on the stomach, the gastric endoscopic bariatric metabolic therapy, and the second which focus on the small bowel, which is the small bowel endoscopic bariatric metabolic therapies. First we will be discussing the gastric ones. So what constitutes gastric endoscopic bariatric metabolic therapies is, first is an intragastric balloon. It is a fluid-filled balloon which is placed in your stomach. It has been there for a long period of time. We have probably used it somewhere else or sometimes in our careers. And the 2 main ones are Orbera and Sparks. Only thing is we have to remove it after 6 months. Now we have balloons which can be placed till 1 year. The newer methods are stomach volume reduction therapies, which can be either endoscopic sleeve gastroplasty or primary obesity therapy for endopneuma or endomina. So we will be discussing about endoscopic sleeve gastroplasty as it is the new kid on the block. Here, there is a device, the suturing device, which is attached to the tip of a double lumen endoscope, and this endoscope is then inserted into the stomach. This is the endoscopic view that we see after we insert it in the stomach. We find that we have a greater curvature and we have an incisura and we have a lesser curvature. We start suturing the greater curvature of the stomach, thereby reducing the volume of the stomach. We take sutures from the greater curvature to the lesser curvature and go back in a U-shaped pattern to the greater curvature. Thereby, when we tighten the suture, we reduce the volume of the stomach. And subsequent such sutures are taken starting distally, ending up to the proximally. Thus, we are creating an accordion of the stomach which is smaller in size than previously. This is the real life endoscopic sleeve gastroplasty video. You can see I am seeing the endoscopic image. There is a handle on tip of my endoscope and there is a suture which is toggling between the handle and the needle exchange catheter. I am taking in the tissue of the stomach using a helix and then doing suturing from greater curvature to the lesser curvature, taking the stomach in pleats and doing a bursting suture. What will this do is, this will reduce both the length and the breadth of the stomach and will create a stomach that is smaller in size than it was previously. We can achieve up to 50% reduction in size of the stomach. Once we do that, what happens? How it works? To understand how this procedure works, we must understand that human appetite has two components. You all must have had breakfast, so how much you eat in a breakfast is satiation. When do you feel full after eating? So that depends on how much you have to fill, how much is the volume of your stomach. Then after breakfast, all of you will have some lunch. When you will feel hungry for lunch will depend on how much your food from the breakfast has gone into the small bowel. This is known as satiety, how long you feel full after the meal. This depends on stomach emptying. When the stomach empties less, it becomes more satiating. So ESG works on both the aspects. What it does, it reduces the volume of the stomach. As you can see in this CT image, that the volume of the stomach previously was more and now it is less. And also the food which stays in the stomach for a long period of time. In the third image, you can see in the SPECT image that the food is staying for 6 hours post eating. So don't feel hungry after a few hours. Thus, in theory, it helps us lose weight. Do we have clinical experience and data to show that? Yes, we have. So the clinical experience and data came from a randomized controlled trial, which is the highest quality of evidence that we can have, which is the MERIT trial, which was done in 9 US centers, both surgeon and gastroenterologists. So you must understand what is the composition. So the persons performing it were both surgeons and gastroenterologists. It was done in both community and academic centers. So you don't need a very big setup to do the advanced procedures like that. So it compared endoscopic sleeve gastroplasty versus lifestyle therapy. You had 200 patients, BMI was 35. The durability was assessed at 2 years. We also assessed whether improvement in weight led to improvement in comorbidities like diabetes, hypertension, metabolic syndrome, GERD. So what results were there were quite surprising. Endoscopic sleeve gastroplasty patient lost 13% of their total body weight as compared to only 0.8% in control. Control arm were given only diet and lifestyle therapy, which is mostly what our patients practice before coming to us. What's more important is 80% of the patient who had underwent endoscopic sleeve gastroplasty actually reported an improvement in other diseases like diabetes, hypertension. Whereas those who had only had exercise and lifestyle modification, 45% of them had worsening of diabetes and hypertension. 80% were highly satisfied with the procedure. They recommended the procedure to their family members. This was extremely safe, with only 2% serious adverse events reported in 150 cases, and all were managed conservatively, no death, or no need for re-exploration or surgery. A systemic review done in 1772 patients reinterpreted these findings with a weight loss of 2 years of 17% total body weight loss and 2% serious adverse events. So to summarize, for endoscopic sleeve gastroplasty, we have more than 25,000 procedures globally till date. We have a MERIT trial which shows that there is clinical evidence. We have more than 200 publications and more than 10,000 participants in ESG trial. ESG is the thing that is ready for the future. What about small bowel endoscopic bariatric metabolic therapies? Why do we need small bowel endoscopic bariatric metabolic therapies? What does small bowel do? So, for a long period of time, people thought that pancreas is the center for controlling diabetes. It seems right. Insulin is released by pancreas. But nowadays, it is thought that the metabolic brain or the control lies with the duodenum, not the pancreas. Duodenum tells the pancreas whether you should release the insulin or not. So what happens when we eat the food? When the food goes into the stomach, it moves into the small bowel. There are two types of cells here. One is the incretin and one is the anti-incretin. Anti-incretin are insulin resistance factor and incretin are insulin supporting factor. So balance of these leads to proper release of insulin and euglycemia. But once there is diabetes or sweet fluid is taken, there is increase in insulin resistance factor leading to insulin resistance, more blood sugar, more triglyceride and NASH. So this is a major problem. We see daily in and out patients coming with fatty liver, raised enzymes and asking what to do. So duodenal nutrient passage strongly influences insulin sensitivity independent of weight change. And insulin resistance is now root cause of metabolic disease. It is not only limited to GI, but to diabetes, to non-alcoholic fatty liver disease, polycystic ovarian disease, young females coming with irregular menses, coronary artery disease, stroke. So, an endoluminal approach to duodenum may decrease the insulin resistance. But does it? So, the first concept came in endobarrier. Here, a lining was placed in the proximal duodenum, which was anchored at the pylorus. And it was found that it improved ALT, AST, liver enzymes, and fasting insulin level. However, because of the barbs that used to hold this lining, they were hepatic abscesses, so it went out of the market. The second product that came in was a duodenal mucosal resurfacing. Here what it was done was, there was a device, it was placed in the duodenum, it lifted the duodenum and burned the mucosa. After burning the mucosa, in 3 months, the normal mucosa came in. But this normal mucosa had good enteroendocrine cells and it helped us improve diabetes and hypertension. We can also see in the biopsy images that in 24 hours you can see a lot of neutrophils are there, dark blue spots. And in 3 weeks you can see there is a normal architecture, normal villi, normal crypts that you are able to see. This can also be done with newer therapies where you don't need to use heat, because sometimes we are worried if you use too much heat it might cause perforation. This is a new device, Endogenics, which uses non-thermal mode of ablation. It goes in the duodenum, beyond the pylorus. It is done in conscious sedation, not a big thing. It inflates, you see with the scope that it has inflated, you create suction, it burns the mucosa. What it does, it sends electric signals which causes apoptosis. Once there is apoptosis of the cells, there is regeneration of these cells, and these regenerated cells have a better control of metabolism. And this leads to improvement in HbA1c, improvement in HOMA-IR, improvement in fasting plasma glucose, improvement in AST, and improvement in ALT. So the potential advantage of an endoscopic therapy for obesity is it is safe, it is effective, it is adjustable to the patient. If your patient wants something, yes, you have options for it. It is reversible if needed. It is minimally invasive, and it has favorable impact not only on obesity but on comorbidities, thus making it more acceptable to the patients. That's the key. The procedure should be acceptable to the patient. The way forward is, fight against obesity is like a game of chess. You have multiple openings, you have multiple mid-games, multiple end-games. It is a chronic relapsing disease. It will hit you in different ways. But sometimes newer things are better, like our world chess champion who became at 18 years, D. Gukesh. And to conclude, endotherapy for obesity, the future is here and this is here to stay. Thank you so much for your patient hearing.
Thank you, Dr. Sarans.
Yes.
Thank you. Nice talk. Hopefully we will be starting this for us also in Bir Hospital.
Yes.
We will have question answers towards the end of session.
Yes, sir.
Thank you.
Thank you.
Our next international speaker is Dr. Matthew Phillips. He will be delivering a talk on US guided biliary drainage. So he is from Kerala, India, and is a current secretary of ISG. And he has a lot of publications, almost 50 publications with hundreds of citations. And he is also a renowned gastroenterologist with more than 30 years of experience in this field. Dr. Matthew, please.
Thank you, Chairperson, for the kind introduction. My dear friends, senior faculty, and postgraduate students, it gives me immense pleasure to stand in front of you. I am coming from the southernmost part of India, flying a long distance to come to the Himalayas. And I thank all of you for giving me this opportunity. I have got good friends here, Ramila, Bobedra, and Mukesh, and so many others. I have heard about all of you. And I'm so happy that gastroenterology is so active in Nepal. And being ISC secretary, I bring in the greetings of ISC to you. And Indian society is very active in disseminating knowledge. So I'm so happy to be here. We will just quickly go through what I'm supposed to deliver. You know that there are different techniques of draining the biliary system. And we are commonly concentrating on three, and that is actually endoscopic drainage, that is ERCP, through the natural orifice, and then PTBD, percutaneous, there you get the radiologist support, and then the new one is EUSBD. But our area of interest today is EUS-related drainage. My outline will be like this: why to choose EUSBD, how I do it, what are the evidence and guidelines on that. Does it have any adverse events? What are the future perspectives and take-home message? See, you know that ERCP is the king for biliary drainage. All the guidelines or consensus say that ERCP and transpapillary drainage is with metallic stent for malignant biliary obstruction is the mainstay of treatment. Then why do you need more procedures other than ERCP? We know that ERCP has moved in the past. ERCP was, even I have done ERCP as a diagnostic modality when I was initially doing that. Now it has moved from that to therapeutic modality. And we know that, as I told you, it is the first line of management, and it has got very high success rate. But there is at least in some percentage of it, it is not possible. The reason could be many, or that can also have some complications. The papilla cannot be accessible because of surgical reasons or because of neoplasm, or there will be some failure of cannulation also. And the major challenges in ERCP are this: only is a difficult cannulation. At least, even if you are an expert, you can actually enhance by needle knife sphincterotomy, or you can use other techniques, but still there is a small percentage we cannot do that. And there are other things, of course, because of patient-related problems like surgery, or patient has got a disease called gastric outlet obstruction. So when you do, what are the indications of doing EUS-gated biliary drainage? It can be either at the lower end of the bile duct obstruction or at the hilar level, both can be done. Or it can be done in a setting of as a palliation or as a setting of a preoperative drainage. So when ERCP is failed, does EUS-BD help? There are good studies, and studies have shown that this is technically and clinically very successful. So what are the steps for doing an EUS-BD? Basically, you need to identify an area where the bowel is close to the biliary system. Two areas are quite good. One is in the duodenum, another is in the stomach. And in the stomach, you can puncture through the left bile duct systems. In the duodenum, you can go into the bile duct. And that is the transmural puncture of the biliary system by EUS. And for that, you need a 19-gauge needle. And second is, you need to have a cholangiogram to find out the anatomy of the biliary system. And for that, you have to aspirate the bile because it's very obstructed, otherwise you can have infections. And you have to dilute the contrast so that you get a good picture, and make sure you are inside the bile duct. Sometimes, if it's a rapid flow of bile contrast, that shows you are in the vascular system. Then you put a guide wire. And guide wire can be either, if you are using a 19 gauge, it can be a 035 or 025 we can use. Then you create a fistula through the intestine into the biliary system where you are puncturing. And this is done by a dilatation of the tract. Finally, you establish, make a permanent structure there so that the drainage is adequate. That is by putting a stent. So there are different types of that. As I told you, you can actually use a transient puncture, pass a guide wire to facilitate your cannulation by a rendezvous technique. Or you can do a choledochoduodenostomy, or you can do a antegrade. You just want to puncture and try to pass the guide wire through the ampulla down into the duodenum. Or you can do a stenting into the biliary system through the transpuncture of the stomach. Or you can do a bridging. For example, there is a hilar block. You want to put a stent there. ERCP is not possible. In those systems, you can actually put a stent initially on the hilum, then you can do also hepatogastrostomy. This is again altered anatomy where you do a HGS by retrograde route, and this is the classical antegrade hepatogastrostomy. And also in rare situations, nothing works out. You can actually put a stent into the gallbladder also. So this is actually a choledochoduodenostomy. I'm not able to reach up to the ampulla. You can see the obstructed duodenum there, and patient has got biliary dilatation. You can see that this is the needle coming out into the bile duct. Quite simple. Only thing is you look for the vessels there. Then you try to enter into the biliary system and dilate. You can see the guide wire. Here we have used a cystostom, and over that we are trying to put a metallic stent. And the drain is over. When you come to hepatogastrostomy, you can see you have to have a dilated system preferably. Even some people do even with minimal dilatation. Then you identify the site, use an EUS, and pass the needle, then do a cholangiogram, then finally you dilate and put it. Here it is actually there is no space in the duodenum. I cannot do a choledochoduodenostomy. In that case, I prefer do a hepatogastrostomy. You can see this is the duct in the left duct. You can do a B2 or B3 system you can go in. Then put contrast, image the biliary system, pass a guide wire, then you can dilate the tract, then put a guide wire if possible. You can go down and put the stent through that. But here actually the patient already had a biliary stent down and duodenal obstruction. So we did a hepatogastrostomy. The best is you have to put a longer stent. Here we have used a geobar stent. You can see there. And we always put a plastic stent to prevent migration when it appears to be shorter there. And this is the picture of that. You can see that the stent is remaining in the left duct system adequately. So when you do ERCP and EUS, the ultimate goal is biliary drainage. Do we succeed in that? Yes. Everything shows that they are equally good. So there are, when you take different parameters like access, difficulty, you look at the stent placement, all these parameters are looked at, it is found that EUS BD has some advantage because you are directly seeing and putting it. So all are equal, but EUS got some advantage as well. So what our studies shows, the guideline shows, everything shows that probably in palliative biliary obstruction, this is very good. Distal biliary obstruction, it is excellent. And in unresectable distal biliary obstruction, this is found to be good. And it is probably, this could be an attractive primary approach as well. But please see that this is not a recommendation. So all studies there are different studies shows that this could be a potential thing. In preoperative, though this can be done, the guidelines do not recommend this. ESG guidelines says that that is not the primary one. Primary is still ERCP. So cost, procedure time, and everything, even training, suggests that probably USBD can be trained better than ERCP. So I really doubt that, but I believe that people should do ERCP first, then only should get trained for USBD. There are multiple studies have shown that probably this could be an option in these patients. So can we use a different type of stent other than self-expanding metallic stent? There are studies on self-expanding lamps. This is it, what you see, that if you are getting an adequately dilated biliary system in the common bile duct, you can try that. There are different studies on that. Both have shown good. I will show you an example of that. This is a case, actually we tried cannulation. It was failed because she underwent a surgery, pancreatic head coring, and hugely dilated biliary system. You can see that. You can see this is a CT scan, gross dilation of biliary system, and we thought we'll put lamps for her. Sorry. You can see that grossly dilated system is almost 3 centimeters there. We use a US grid at 90 gauge needle. Here we have used a guide wire because we want to make sure that we are not losing the grip, and a SEMS is placed. In rare situations, mostly we use it in only desperate situations. You can even use a USGB. This is a case, the patient had a biliary obstruction and also had a cholecystitis, and we actually tried to do a biliary obstruction. We could not succeed, so we put this, and also we utilized this patient to go into the biliary system and gallbladder and remove the stones also. The hard facts are in suboptimal ERCP competency, that cannot be considered as an indication for EUS bile duct drainage. All data comparing EUSBD and ERCP are presently done in high volume centers. So only your experience in ERCP, I would recommend that you should go for that. Can we actually generalize these terms in everyone? In the current scenario, my recommendation is that as a backup intervention, when ERCP fail, this can be considered. As a primary modality, when you are in an expert center, when you have got all the facilities possible, there are a lot of complications can occur. And studies have shown that EUSBD do also have complications. But when you compare with ERCP and EUS bile duct drainage, the re-interventions in EUSBD is slightly lower than ERCP. These are the different side of adverse events like bleeding, bile leak, cholangitis, cholecystitis, etc. And I'm coming to my last few slides. Can it be a primary therapy? What are the future perspectives? There is better familiarity, widespread availability should be there. There should be dedicated accessories because you should have to have a rapid, because lot of exchanges, there will be leak. I'm finishing, don't worry. And then adverse events should be in the acceptable range. This is actually an algorithm. I'm not going into detail of that. So in take-home message, our aim is to have a biliary drainage. You should be a master, or you should have a reasonable proficiency in both the procedures, ERCP as well as an EUSBD. And our mindset as well as skills guide us what to choose. Cost, reintervention, stents, everything has to be considered. So everything should be centered around the patient. So keep the patient in the center of your management. And this is my last slide. And I request all of you, there are two major events happening in India. One is the Colitis Crohn's Foundation of India is having its annual conference in August. That is in my city in August 22 and 23. I request all of you to join that. Whatever support I can offer from our side, I will definitely do that. And the National Conference of Indian Society of Gastroenterology is happening in Amritsar. That is in December. I request all of you to join for that and welcome all of you. Thank you so much.
Thank you very much, sir. Now, floor is open for question and answer session.
I have a question to Dr. Sarans. Dr. Sarans, So we have yet to start any endoscopic therapy for obesity in our country. So how does one go about it? Where does one get a training, and which patient's type would you like to select for the first few cases?
Hi. When we talk about training for a procedure, there are 3 steps to training. The first step is understanding the equipment. The first thing is you must know how the equipment work. So all of us have done an upper GI endoscopy, and in most of our training centers, a few days or few sessions were also to how to clean the scope. So understanding the equipment is the first thing. So a representative of Boston Scientific can help you in understanding the equipment, how it is done. The second step is using the equipment on an animal model or ex vivo model. So that also can be done in either conferences, or the Boston rep will come over to you and they will do it. The third step is then starting the procedure. That is the key step, because that is where you would be having technical issues which are not usually seen when we are doing an ex vivo models. So here I would recommend that first few procedures you should observe at a high volume center. See how the person is doing it. So I have a center, 3 or 4 centers in India are there who are doing regularly these procedures. You should go there for a week or 2 to observe not only the procedure, but the pre and the post. How do we admit the patients? What do we do 24 hours before the procedure? What is done on the day of the procedure? How does the patient get discharged? What are the dietary and lifestyle modification given post-discharge? And how is the patient being followed up? So that's also important. Not only the procedure itself, but the pre and the post are important. It's a chronic disease. The patient is going to come to you for follow-up. Then once you have done that, then after observing 2 or 3 cases, you have to have one person hand-holding you for the first 5 cases. You start, you do the procedure, but the person is there to handhold you for any issues that you might face during your initial days. That is most important, and then you can ride and soar high as possible, because the patients are there. There is obesity, everybody knows there is obesity. It's just that we are afraid to tackle it as a gastroenterologist. Actually, but they come to us first. They come to us with fatty liver. They come to us with residual enzymes. So we are the one who can treat them early and get them rid of their situations. I hope that answers the question.
In that perspective, wonderful answer. I just want to add something. Before we actually take up a problem, we need to see whether it's a real problem in our country, in our state. So actually, you should do a preliminary analysis. That is the best thing, And second is create a unit. Learning is not difficult. Doing is not difficult. You create, because you make a system where these people have looked after. The reason is lifestyle modifications, lifestyle changes and all. So you would have a clinic first, an obesity or overweight clinic, where you should have dietitian, you should have trainers, you should have people to understand their problem, and you should actually give them training the people or educating them how to lose weight without these things. Then only you should actually come for medications and other things. But I agree, these are all wonderful things. But other thing what I have seen is, I have seen people doing EBG. Then finally they come with all, they do a sleep gastronomy, they come with all leak and all those things. And if you are not able to manage all those things, then I think better you get trained. And moreover, it's a teamwork. You should join with your endocrinologist. And that is the most important key person in that team. And then you and a wonderful dietary team. I think these are the 3 people should be very key people on that.
Yes, clinic concept is actually very important. Multidisciplinary team approach, this is the formal name for the concept that he has given. And that is the baseline on where we start ahead.
That was an excellent talk, Dr. Saransh. Can I have a question? Yeah, okay. So that was an excellent talk. My question is, now we know that there are benefits in terms of reducing fat and reduction of weight, as well as improvisation and the metabolic profile of this patient undergoing bariatric procedures, right? But will it ever match with the benefits of exercise and diet, especially with regards to muscle mass and the protein intake?
So I think the question is, do we, I think you misunderstood the concept. All the bariatric procedures, balloon, endoscopic procedure or surgical procedure, always done with diet and lifestyle modification. Without diet and lifestyle modification, these won't work. So all your patients have to have a willpower to lose weight. If they are going to eat a pizza every day, it's very difficult for the patients to lose weight. So they must have a willpower to lose weight. Diet and exercise also create another benefit. The benefit is, once you exercise, your muscle mass improves. Your muscle mass is the driving factor behind your basal metabolic rate, because you won't exercise all day. Once in night you're sleeping, your basal metabolic rate is the one which burns your calories. So there are two phases to weight loss initiation phase and weight loss maintenance phase. So initiation phase, you have a diet, you have diet restrictions and all. And maintenance phase, the restriction is not that much because the muscles have built up, replace the fat, and they take care of the basal metabolic rate. So very good question. All these interventions are with diet and lifestyle modification. Diet, you have very less fat, less carbohydrate, very high proteins. Lifestyle, at least brisk walk 60 minutes per day, 10,000 steps per day. That's important. And calorie restricted diet, 1500 kilocalories, 1 gram per kg protein per day. That's summarizing the diet and lifestyle.
Sarans, duodenal mucosal resurfacing, which centers are doing in India? And
So
what is the cost
duodenal
like?
mucosal resurfacing presently is done in trials. It is not being done in commercially because the product is not available commercially. It is being done in trials presently.
Yeah, any centers in India under priority being done?
The centers are in Australia and US and few centers in Europe, but it is going to be available probably next year for us. Next year.
Is it likely we are going to have one trial center in India? You are planning somewhere in
Yes,
India?
once it commercially available, then only we can plan for a large or a small center. Whatever the center has to be planned, it has to be planned only when the product is FDA approved and commercially available.
Okay.
Presently, it is in phase 2 and 3 trials.
Now, if we don't have any questions, I think we should move ahead now.
Thank you, Dr. Sirens and Dr. Matthew, for this wonderful talk. Now, I would like to request the speakers and the chairperson of the session to be on stage. I would like to request the chairperson, Dr. Jeevan Thapa, to provide the token of love and certificate to Dr. Saras Jain. Now I would like to request Dr. Sitaram Chaudhary to provide token of love and certificate to Dr. Matthew Phillips.
Now coming to the next session, that is the liver session. I request the chairpersons, Dr. Vivek Malla, Dr. Subhas Bhattrai, Dr. Arvind Pokhrel, Dr. Rupesh Shrestha to chair the session.
Good morning, all. Now, this session we are going to start on liver. We have got excellent speakers. We have got Dr. Anand Shrestha from Alka Hospital, then Dr. Pratap Sagar Tiwari from Noble Medical College, and Dr. Pukar Thapa. So, may I first please ask Dr. Anand Shrestha for his first topic on dynamic human reservoir in hepatitis E, the concept. Thank you.
Yeah, at the outset, I would like to thank Dr. Mukesh, Dr. Divas, and the entire team for organizing such a lovely meet. So my talk is basically a bit conceptual one, and you may find a bit boring after a very interesting endoscopic lecture with lots of videos and technical things. Yeah, that's it. So I have nothing to disclose. And next 8 minutes or so, I'm going to talk about the dynamic human reservoir concept on hepatitis E virus. We all know that hepatitis E virus is a very important public health problem worldwide, nearly about 20 million infections, as well as 3.4 million symptomatic cases and 7,000 deaths and 3,000 stillbirths. If you look at the world map, there's a dichotomy in terms of genotypic distribution. The developed nations or industrialized nations like United States or in the Europe and in the Japan, you'll find genotype 3 and 4, which is transmitted by eating raw meat and basically a foodborne disease, less likely to cause outbreaks or epidemics and doesn't have very high mortality rates. But then it can cause chronic infection. But then in Asian subcontinent and underdeveloped regions, we have genotype 1 and 2, which is waterborne disease, is likely to cause outbreaks and is known to cause lots of deaths in high-risk population like pregnant women. Now, if you look at the epidemiology of hepatitis E virus in Nepal, so it manifests as acute icteric and anicteric hepatitis, especially among young people. We have predominantly genotype 1 infection. To be specific, it's genotype 1A, and usually a self-limiting disease. In general population, there's morbidity. The mortality is very less. It's about 0.4%, but the specific treatment is unnecessary in this patient. I think my slides are all scrambled. But in high-risk group like pregnant women and patients with chronic comorbid illness and those patients with chronic liver disease, there's marked morbidity, there's marked mortality that may reach up to 25%. Specific treatment is highly desired but yet unavailable. So going back to the epidemiology of hepatitis in Nepal, so we have documented at least 5 major outbreaks, 1973, 1981, 82, 87, 2006, and 7 being 4 epidemics in Kathmandu, and the latest one epidemic that occurred nearly about 10 years back in city of Biratnagar in 2014. And all of these, the initial 2 epidemics were actually presumed based on epidemiological characteristics because at that time hepatitis E virus was not even discovered. But then later, last 3 outbreaks have been confirmed, both serologically as well as NAT. Now, if you see, in between these outbreaks or epidemics, what happens is these viruses go into quiescence, or they tend to disappear, or even if they occur in a very low sporadic fashion. And to be very honest, after the outbreak of 2006 and 7 in Kathmandu, we actually haven't seen any major cases of hepatitis E virus in our clinical practice. It's been nearly approaching 20 years. So where does this virus go, right? And we also see that there are lots of mortality during these outbreaks. So if you need to reduce this mortality, we have to prevent outbreak or epidemics. And if you want to prevent an epidemic, we have to understand it. So our first question that came in our mind was why periodicity, or why there is periodic epidemics, and where does the virus go in between these epidemics? So we had a couple of preconceptions that there may be change in virus antigenicity or genetic mutations. We did studies on that. We didn't find there was any major serotypical changes, so this was not possible. Another thing is, could it be because of waning of herd immunity? This is a good possibility given that the population of Kathmandu is a drifting population. It keeps on changing. People from rural areas, they tend to migrate into urban for work and better opportunities, and people in young youth people are flying abroad. So the population is changing, so the herd immunity can change, and that could be one thing. But we couldn't understand why periodicity and why would epidemic often last for about 1 to even 2 years, which is very uncommon as compared to other regions, and where the virus goes in between. So after 2006 and 7 outbreak, HIV disappeared from Kathmandu. And one question that we always discussed was, will it again reclaim its existence in the valley, or will it again come back or not? And to answer this, we have to find out if there are any possibility of reservoirs for genotype 1. So there are a couple of studies done in Nepal, which showed that in swine and in rodents, hepatitis E virus existed. But all of these hepatitis E virus were genotype 3, not known to cause outbreaks or acute epidemic. So this hypothesis was again taken out. So for genotype 1, it does not cross species barrier. There are no animal reservoirs for HIV genotype 1. So what could be the possibilities? So where does the HIV hide during quiescence or in between epidemics, again to reappear among outbreaks? So out of nowhere, we were actually doing one big study among blood donors. We were trying to do some serological studies. 581 blood donors, 401 males, 180 females, predominantly young people, 35 years. We found that anti-HIV IgG was about 8.4%. Surprisingly, we also got HIV RNA in healthy blood donors at the tune of 1.56%. So 9 out of 581 individuals actually had HIV virus in their blood, and all of them were genotype 1. So genotype 3 and 4 is pretty common in the Europe, and it is known to be a blood-borne disease. But for genotype 1, it was very surprising. All these individuals were asymptomatic during follow-up. They had normal liver function test. There was no hepatitis. And surprisingly, most of these people didn't have IgG or IgM in these blood samples. And there was 97% homology between these isolates, 95% homology with the isolates that was taken from the 2014 Biratnagar outbreak, and we did this phylogenetic analysis and we proved that. When we looked back in the literature, similar studies, we came across similar studies by Dr. Muhammad Sultan Khuru in Kashmir, when they tried to match, or they tried to compare patients who got multiple transfusions of blood versus those patients who didn't. And what they found was those people who got multiple blood transfusions had HIV RNA positivity at the tune of about 5.5%. So this proves that HIV genotype 1 can be transmitted through blood. That is one of the observation. The same study had a prospective arm where they studied 107 blood donors, out of which 4 were found to be HIV RNA positive. All these patients were asymptomatic. And there were 25 subjects who received these multiple transfusions. And out of these 25 subjects, 3 developed acute HIV infections, as evidenced by HIV RNA positivity. But then it was not clinically significant, because patients were not symptomatic. Whereas those patients who didn't receive any transfusion, none had HIV. Similarly, Dr. Arankeli from Pune also documented similar findings, that out of 200 blood donors in their cohort, 3 were positive for HIV RNA positive. Again, similar to our study, where they found that anti-HIV IgM was found only in 1 out of 3 viremic subjects. So subclinical asymptomatic HIV in this region is very common, and most of these patients are asymptomatic. There is no clinical hepatitis, and maybe transmission transmitted, but then its significance is unknown. So can asymptomatic HIV subjects shed the virus in their feces, or can they transmit this infection to others? That was another question. And this paper in Lancet proved that during an outbreak in Kosovo, they had 4 patients who were asymptomatic HIV patients, and these patients had HIV fecal shedding of hepatitis E virus on follow-up. So decoding these observations, HIV outbreaks are frequent. In Kathmandu, clinical HIV disappears in between outbreaks. Subclinical viremia infection does, however, exist. Covert transmission of HIV may be keeping the virus in the community. There is no known animal reservoir in hepatitis E virus genotype 1, and chronic HIV doesn't occur with this genotype. These subclinical transient infected individuals may actually act like transient human reservoirs. So it's kind of, those people are getting infected unknowingly, they're asymptomatic, and they tend to lose the virus over a period of time, but again, they will be transmitting others. So that's how the virus is being kept in the system. And we proposed this term called dynamic human reservoir for the first time, and we published this paper last year in World Journal of Hepatology and was taken pretty well. So this dynamic human reservoir is a new terminology that we propose for the first time, and this not only works for hepatitis E virus, this probably will work even for explaining the phenomena in infections like COVID infections and all. So, but then what we don't know at this moment is why does some individual develop clinical illness of varying severity while others don't? Why IgM and IgG fails to mount in subclinical infections? Does subclinical infection provide immunity for future HIV infections? We don't know the whole genome sequence of HIV isolates. We tried, but then we failed because of the low viral load. And what impact will this phenomenon have if HIV vaccine is to be implicated or approved? Thank you very much.
Thank you, Dr. Anantas. So the next talk is by Associate Professor Dr. Pratap Sagar Tiwari from Nobel Medical College. We will be talking on the changing landscape of beta blockers in chronic liver disease.
Good morning and namaskar. My thanks and congratulations to the Gastro Update team. Respected seniors and colleagues, the course of chronic liver disease, which begins with early fibrosis and eventually it leads to the most advanced stage, the cirrhosis. We know CLD can remain asymptomatic for decades, but once becomes symptomatic, there is a rapid downhill course. Thus, it is important to recognize the distinct turning points in the course. In cirrhosis, we have a stage of ACALD, advanced chronic liver disease. In the earlier course of ACALD, the disease lies in the compensated form, the CACALD, and then over time it progresses to DACALD with decompensating events, the common one being ascites and varicose bleeding, and then we have a stage of further decompensation with further complications. And the outcome of the patient worsens as the condition progresses. Now, why am I telling you this course of illness? Well, the studies of the past decades have helped us to understand how we can manage the complication in DACALD. However, in the present context, there is large body of evidence that indicates that therapy, if done in ideal time, it not only slows down the disease progression, but also may induce disease regression as well. Moreover, Babino 7 has recently introduced the recompensated stage, though which requires further studies. Well, there is no doubt that transition from CACALD to DACALD carries high mortality rate. And thus it is imperative to take action in order to prevent progression, not just manage this complication. Now the question arises, when and how? Well, portal hypertension being the major driver of this transition, and once SVPG is above 10, we have the sub-stage CSPS, clinically significant portal hypertension, and this is indeed the threshold from which decompensating events begin to occur. So now we know the answer to the question when, and next question remains how. Now, apart from the etiological therapy, while talking about pharmacological therapy, I'm here to talk about non-selective beta blockers and its journey. We know beta blockers have been mainstay of treatment for portal hypertension for the past 45 years, ever since Leverek et al. Demonstrated in 1980 that continuous administration of propranolol at a dose that reduced the heart rate by 25% produces sustained reduce in portal venous pressure. This effect led to the view that propranolol might be useful in preventing the recurrent GI bleed. Then in 1981, the same group studied 74 patients who were admitted because of a GI bleed. And in the study, the percentage of patient free of bleed was 96 in the propranolol group and 50 in the placebo group. Thus, the study concluded that propranolol is effective in preventing recurrent GI bleed in patients with liver cirrhosis. Then, subsequent studies expanded the role of beta blockers. Evidences from many other studies were accumulating regarding the role of beta blocker in reducing portal pressure, in preventing first variceal bleed, in preventing recurrent variceal hemorrhage, and thus establishing its role as both primary and secondary prophylaxis. And also it seems to have a role in severe PSG, and there also seems to have a survival benefit as well. Then came a twist in the storyline. 30 years after the seminal report of the same French group, Levrec et al., they raised an alarm concerning the deleterious effects of non-selective beta blocker in patients with refractory ascites. In their observational study, the median survival was 5 months in the beta blocker group and 20 months in the other group, and the study concluded that use of non-selective beta blocker in such patient was independently related to mortality. These results challenged the indication for beta blocker and spurred the scientific community to question their effects on the role regarding the advanced stage cirrhosis. Then consequently, considerable observational data emerged and eventually led to the so-called therapeutic window hypothesis, stating that the beneficial effects of beta blockers are lost in the advanced stage cirrhosis when the cardiac compensatory reserve is exhausted, thus closing the role of beta blocker in the advanced cirrhosis. And there was also a timolol study by Grossman, not shown here, which have shown that beta blockers have no effect in the earlier course of cirrhosis when there is nil to mild hyperdynamic circulatory state. Overall, it was suggested that beta blocker improves survival only during a certain window in the disease. Well, we'll come back to a window in a while. Meanwhile, in 2011, Alexander Craig, they published a meta-analysis which was done to assess the beneficial effects of beta blocker. Well, the study results showed that there is a mortality benefit. But what was more interesting was that there was no apparent differences in terms of bleeding-related mortality across all groups. This finding suggests that additional effects not related to the risk of variceal bleeding may exist, thus further reinforcing the non-hemodynamic role of beta blocker, which was also shown by other studies. Now coming back to the window, as I've earlier mentioned, that the beneficial effects are lost in the advanced stage, and beta blocker has no role in the earlier stage, creating a so-called therapeutic window. Now the question was, when does this therapeutic window opens? And the question was to be answered in an ongoing study at that time, and the study is the Predisky trial with primary endpoint of decompensation. The study showed that long-term treatment with beta blocker could increase the decompensation-free survival in patients with compensated cirrhosis and CSPS, and mainly by reducing the incidence of ascites. Now further highlighting the role of beta blocker as a preventive therapy in ascites, when no preventive therapy for ascites was previously available. It has important clinical implications, suggesting that all patients with compensated cirrhosis should be screened for development of CSPS, and that non-selective beta blocker should be started from its detection. Well, in this journey of beta blocker began its journey by demonstrating its ability that it can reduce portal pressure. Then eventually it established as a primary and secondary prophylaxis in terms of variceal hemorrhage. And in addition, it exhibits the non-hemodynamic and the pleiotropic effects. Then its overall properties contributed to reduction in progression to decompensation and improved survival. This journey, however, had many challenges as well. The studies, many RCTs and meta-analysis have reported the mixed and negative responses as well. Even the studies I have shown here have their own limitations. I am not denying that. But collectively, they present a framework of to understand the evolution of beta blocker therapy in portal hypertension. There are still gray zones for which, regarding which we cannot state with certainty in the present context. There are still research agendas for which studies are ongoing, and hopefully they will shed lights on those gray zones in the upcoming days. I would like to conclude my talk by displaying this summary slide regarding the role of beta blocker in portal hypertension. Thank you.
Thank you. Now I'd like to call upon Dr. Pugar Thapa, last speaker for the liver session, on the topic of treatment of drug-induced liver injury.
Good morning, everyone. First of all, I'd like to thank Dr. Mukesh and his team for this opportunity to talk on treatment of drug-induced liver injury in this forum. Today, I'll be focusing on the treatment of drug-induced liver injury. As we know, drug-induced liver injury is a common problem occurring between 2.3 to 13.9 per 100,000 per year in various studies. So it is a uncommon but challenging clinical problem because of myriad of drugs that is used in practice. Herbs and dietary supplements with hepatotoxic potential, they are being used commonly in our part of the population. And then ability of the condition to present with a variety of clinical and pathological phenotypes, and also absence of specific biomarkers. So there was a study published in Journal of Clinical and Experimental Hepatology in 2021 from India, where they mentioned that anti-tubercular drug almost consists of 50% of the drug-induced liver injury. The other common drug that caused liver injury was complementary and alternative medicine. And in our practice, in our context too, the anti-tubercular drug is the most common drug that is used, that is causing drug-induced liver injury, followed by alternative medicine, herbal medications, and we also have seen few hormones that has been used like testosterone and progesterone. They also cause drug-induced liver injury. So minor increase in AST and ALT or AST that could result from this adaptive and reversible liver response to the drug, and also if the patient has pre-existing liver disease, shouldn't be classified as a DILI. So whom to classify it as a DILI? There is a case definition. So if the ALT rises more than equal to 5 times the upper limit of the normal, so if alkaline phosphatase is more than 2 times, more than equal to 2 times the upper limit of the normal, along with the elevation of ZZT, and if ALT is more than 3 times the upper limit of the normal, along with bilirubin of more than 2. So if the patient's transaminitis follows this criteria, then they can be classified as DILI. So chronologically, drug-induced liver injury occurs with the start of the drug. So the interval between the beginning of the treatment and onset of the liver injury, typically it occurs between 1 week and 6 months. So that's the term called challenge. So after the stopping of the drugs, that is, if we de-challenge, then the regression of liver abnormalities occurs. Suggestive, if it decreases by more than 50% within a week, is highly suggestive of de-challenge of a drug. So a re-challenge is the relapse of liver abnormalities after re-administration of the offending drug. So this is the strong positive criterion and single signature for the role of the drug. So how do we approach the patient with the abnormal liver function test? So if we have DILI suspicion, then first we look for supporting toxic etiology like involvement of the skin, involvement of other organs, especially kidney, and also the history of previous DILI episodes. So we should be inquiring about the exposure to herbal and dietary supplements, over-the-counter drugs, and all other possible factors that the patient has been taking. So the potential pitfall of this inquiry can be lack of information, because the patient doesn't know the dose and duration of the drug, and also the patient may have been using several medications. So first thing to do is to discontinue the non-essential drugs or hormone or dietary supplements. So after that, we calculate the biochemical pattern of the liver injury, and then we calculate the R score. Accordingly, if it is more than equal to 5, it's hepatocellular. If it is more than less than equal to 2, then it's cholestatic or mixed type of pattern in between. So we search for the alternative causes like viral infections, alcohol-related liver injury, autoantibodies, and then we also look for benign and malignant biliary obstructions, primary biliary cholangitis, or any other autoimmune diseases. And liver biopsy is only considered if we have no answers for this, but liver biopsy is not conclusive, because there is no fixed pattern of the fixed pattern seen in the liver biopsy in any of the drug-induced liver injury. So there are a few scoring systems. Among them, RUCAMS is the most commonly used, which has a sensitivity of 86% and 89%. All these biomarkers have the similar patterns and similar biomarkers. Scoring system, they use the similar biomarkers, that is ALT and alkaline phosphatase. So, but these scales do not substitute a physician clinical judgment for liver injury that is caused by drugs. So the first general measures, what do we do? The first is to discontinue the implicated agent or any suspected drug that is being used. So at the same time, we should be assessing for the severity of the liver injury, and then if the patient have jaundice and features of acute liver failure, which is denoted by hepatic encephalopathy or raised INR, they should be hospitalized and very closely monitored. So there are few drugs that are used in drug-induced liver injury, like cholestyramine, that can be used in drugs in injury that has been caused by leflunomide, torvinafine. Carnitine can decrease the course of valproate hepatotoxicity. The use of N-acetylcysteine in non-paracetamol poisoning, it is not a proven drug for, it's proven drug for acetaminophen poisoning, but for non-acetaminophen poisoning, it's not, there are not much studies which shows the much benefit in the non-acetaminophen poisoning, acute liver failure or injury. UDCA can be used, but there are limited evidence, inconclusive evidence for UDCA. So silymarin is a flavonoid extracted from milk thistle. So the main component is silibinin, which acts as a free radical scavenger and modulates enzyme associated with the development of cellular damage. It can also be used sometimes as a prophylactic drug for in ATT-induced hepatitis, chemotherapy, and chemotherapy-induced hepatitis. So there was a study in China where they added silymarin in a group of patients who were undergoing chemotherapy. So in that group of patients, the liver injury was less in comparison to the group who received chemotherapy but didn't receive silymarin. So in drug-induced acute liver failure, the first thing is to use temporary replacement of hepatic function, like extracorporeal devices, which can be artificial like Mars, Prometheus, or bioartificial systems, or bioartificial which uses human hepatocytes and acts as a bioartificial liver. So, but the studies are limited. Liver transplantation is still the primary rescue for treatment for acute liver failure caused by drug-induced liver injury. So the first thing is to do rapid depuration, that is stop the drug which is a culprit, and administration of antidote if possible. Charcoal can be used in paracetamol toxicity, best effective within few hours, and N-acetylcysteine in paracetamol toxicity. It can prevent progression to more severe hepatic injury. So beyond ALT, what are the circulating biomarkers for DILI? The new biomarkers that are being studied are microRNA, keratin 18, glutamate dehydrogenase, and then there are a few other biomarkers, but the most studied biomarkers are microRNA and then glutamate dehydrogenase, which has the best evidence. So they actually detect the drug-induced liver injury, detection and also the mechanism of drug-induced liver injury. They detect the mechanisms. So these are a few of the biomarkers, other biomarkers, and among them, microRNA and GLDs has the best evidence because of the they were conducted on major RCTs. So for the novel therapies for the treatment of drug-induced liver injury, there are a few drugs that has been studied in the drug-induced liver injury. Among them, bicyclol and then MGIZ is there are a few studies where this drug was studied. And then one major random control trial among the patients, 168 patients, showed that these two drugs are beneficial in treatment of drug-induced liver injury. The other drugs, few drugs are mentioned there. So the mechanism with which this bicyclol and magnesium isoglycerisinate occur, the mechanism of these drugs, the action are due to by membrane stabilizing activities, inhibition of inflammatory cytokines including TNF-alpha, and then another is scavenging and neutralizing free oxygen radicals. So lastly, there are a few unresolved issues and unmet needs in treatment of drug-induced liver injury and also overall drug-induced liver injury. There are very few studies to evaluate the risk of herbal and dietary supplement-related liver injury, botanical identification, and chemical analysis. So factors that unmask or prevent liver injury is not being well identified. And also the determinants of severe liver injury, except for pre-existing chronic liver disease, that has to be studied. And then discovery, evaluation, and validation of these new biomarkers still required so that we can diagnose drug-induced liver injury through novel biomarkers, because still the established biomarkers are not well validated. So there should be randomized control trial to evaluate the effective of specific interventions on the clinical outcome of DILI. And then lastly, algorithm that reliably predict the DILI liability considering drug host factors are required for to predict the possible drug-induced liver injury in the susceptible patients. Thank you. Thank you.
Thank you, Dr. Pukar, for your excellent talk regarding drug-induced liver injury. I would like to end this session, and I would like to open the question-answer session. If there are any questions, please.
Thank you all the speakers of this session. Now I request the chairpersons and speaker to come on stage, please. I request Dr. Subhas Bhattrai to provide token of love to Dr. Anand Shrestha. Dr. Arvind Pokhrel to provide token of love to Dr. Pratap Sagar Tiwari. Dr. Rupesh Shrestha to provide token of love to Dr. Pukar Thapa. Now I request everyone to proceed for tea break. We'll begin the next session by 11:15.
low, 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 hello. Low, low, check. Low. Check, low, low, check. Low, low, check, low, low, low. Hello, check, low. Hello. Hello, hello. Hello.
Hello. Hello. Hello, are you listening now?
Hello, check. Hello.
Low, low check. Low test 1 2. Low, low test. Check so. Low.
हेलो
हेलो मुकेश
अमृत दाई
म सुन्दैछु
मलाई देख्नु त भएको छैन होला सायद म
देखिरहेको छु म तिमीलाई देखिरहेको छु
हो दाइ ल ठिक छ त्यही चेक गर्नलाई मात्रै हो तपाईँको भिडियो चाहिँ आएको छैन एकचोटि त्यो पनि
ल म भिडियो अन गरेँ अहिले आयो देखियो
आयो हो देखियो दाइ अब स्लाइड पनि एकचोटि देखाउनुहुन्छ कि
ए ल स्लाइड अब
ए ल नाइस त्यसलाई उ गर्नु त फुल स्क्रिन टाइप
यो म यो
प्रेजेन्टर भ्यू गर्नु अथवा
प्रेजेन्टर भ्यू ल प्रेजेन्टर आयो स्लाइड्स
अर्को स्लाइड पनि आयो दाइ उताको पनि देखियो तपाईँले
ए यो
हामीलाई देखिरहनु भएको छ नि होइन मलाई र
यो म गर्छु यो यसमा देखियो अब
यो ठिक छ दाइ यो ठिक छ हुन्छ
ए ल ल हुन्छ
भिडियो जस्तो भिडियो त होइन नि यो तपाईँको
यो भिडियो होइन यो उनी हो यो रेगुलर स्लाइड नै हो यो
ए ल दाइ ल हुन्छ ठिक छ अरु के
अहिले म्युट गर्छु अनि त्यहाँ सुरु भएपछि भन्नु म सुनिरहेको छु
हस् म यहाँ प्रज्वल सुरेशसित कुरा
हेलो दाइ नमस्ते
नमस्ते सुरेश के छ खबर
यार यहाँ र गफ गर्नेला भने त त्यहाँबाट गफ गरेर के स्वाद पर्यो ल ल दाइ अहिले सुनौँला हजुर बोलेको
पछि कुरा गरौँ नि यसो
ल हस् दाइ बाइ
ल बाइ ल धेरै खुसी लाग्यो
तपाईले होल स्क्रिन शेयर नगर्नु रे प्रेजेन्टेसन मात्रै शेयर गर्नु रे त्यो म्याकको साइडमा त्यो अरु जुम पनि के देखिरा जस्तो लाग्यो कि के हुन्छ र
अहिले म जस्ट हटाएको छु म अब देखाउँछु यो अहिले हेर त अब ठीक छ पुरै
अब ठीक छ दाइ
ए ल
त्यो अर्को स्लाइड गर्नु त अर्को स्लाइड गर्नु त एकचोटी
अब ठीक छ
हैन ल ठीक छ दाइ एकदम राम्रो दाइ कस्तो राम्रो देखिन्छ ल तपाई कुन स्टेटमा रे कुन ठाउँ अरे तपाई भएको भन्नु होला है सबै
के भने
आफू भएको ठाउँ भन्नु होला भनेको के इट इज 4 AM इन द मर्निङ हो कि अब कति हो टाइम यताउति है
अहिले चाहिँ ल 1:23 भइसक्यो
ल दाइ ल ल अब 10 मिनेटमा हामी सुरु गर्छौँ है
ए हुन्छ ल ओके ल
Welcome back, everyone. Welcome back after this. May I have your attention, please? Welcome back, everyone, after this short tea break. Now, we would like to proceed with the next session. Now, we would like to proceed with our next session, that is small and the large bowel session. I would like to request the chairperson of this session, Dr. Sashi Sharma, Dr. Bhavesh Thapa, Dr. Bikal Gimire to chair this session.
Okay, now we'll start the next session. This session, small and large bowel session. So I welcome you all, the participants. And first speaker, we have Dr. Amarendra Mandal. Dr. Mandal?
Yes, sir. One second.
If not...
Yes, sir, can you hear me?
Dr. Mandal?
Yes, sir, I am here.
Oh, sorry, he's alive. Okay, Mandal, now we'll invite you for your topic, cold is the new hot. Okay, Dr. Mandal.
Yes,
oh, sorry, I didn't see you are in live. Thank you.
Yeah. Thank you, sir. Thank you, Dr. Sashi, sir, for giving me the opportunity, and organizing committee for giving me the opportunity to speak at the Beer Update 2025. And this place holds a special place in my heart. It has played an important role in shaping my journey. I am currently in Georgia, United States, and it's 1:30 a.m. in the morning. And I'm very excited to present in front of you all. And seeing you all, my colleagues and my mentors in the audience, makes me very happy today. And I'm excited to give my talk today. The cold is cold is the new hot. So this is a very exciting topic I'm going to present, and let's get started. So the objectives of this talk is to highlight the best practices for the endoscopic mucosal resection in the colon, discuss the indications of the cold snare EMR for the colon lesions, compare recent data on the safety and efficacy of the both techniques. So what is cold snare polypectomy, cold EMR? It's basically the resection of the colon polyp without the using the thermal energy, like electric energy, without using that. And there are a lot of advantages for not using the electric energy while removing the polyps. Like there are very negligible risk of bleeding, perforation, muscle injury, and post-polypectomy syndrome. However, there are disadvantages as well. There might be high recurrence rate of polyps seen on follow-up colonoscopy, especially for the large polyps. And technically, sometimes it may not be possible to remove all the polyps, colon polyps, especially when the polyps is bulky, and in some lesions with the fibrosis, underlying fibrosis, as well as some polyps having pedunculated. So these polyps may not be removed with the cold snare. This slide is taken from the United States Service Task Force 2020, where we can, if you look at the slides, on the left side here, I'm pointing out. So for the diminutive polyps, that is size of less than 5 millimeter, they have recommended cold snare polypectomy essentially for all the polyps. But we can use cold forceps if the polyp size is less than 3 millimeter, but invariably all polyp of less than 5 millimeter cold snare should be used. The polyp size of 6 to 9 millimeter, they have endorsed cold snare polypectomy to achieve in block more. Here is the thing where we have to think about whether to use the cold snare or to use the hard snare. And there are a lot of data since then, 2020, emerging that shows cold snare polypectomy or EMR, cold EMR, as effective as hard EMR in the selected group of polyps with this size. But if the size is more than 3 centimeter or 4 centimeter, then cold EMR may not be effective. So I'll be talking about these studies in the subsequent slides. So I have talked, sorry, it's going opposite. So this slide shows that I'm not going to talk about the detail of the techniques, but you can, in the interest of time, but you can see on the left side is the cold snare polypectomy. On the right side, you can see the cold EMR, where the injection is given into the subcutaneous submucosa to lift the tissue, to lift the polyp, and then cut with the snare. So it can be just regular polypectomy or cold EMR or cold snare EMR with in the piecemeal fashion. So you can do 3 different ways to remove the polyps based on the size. Now this is good to know. There is a size, something called size morphology site scoring system. And this has been, there are several parameters like size of the polyps, morphology, site, access. So based on these parameters, the polypectomy can be categorized into the level 1 to level 4. Level 1 being the predicted success rate is very high, with the level 4 being very complex, often requiring advanced expertise and referral. So this can help us to determine if the polyp can be removed at the time when we are doing the colonoscopy, or to refer to higher center where they are advanced expertise. Now, I would like to present this one slide here. So once we do the colonoscopy and once you see a polyp during the colonoscopy, we need to find whether to assess the size, the morphology, meaning like, it's a protruding polyps, that is pedunculated polyp or sessile polyps or flat. Based on the Paris classification, we can categorize that. And then and the third is the surface pattern. Usually we do the NICE classifications to categorize these polyps, which is optical diagnosis, can be categorized into type 1, 2, and 3. Type 1 being hyperplastic polyp or sessile-situated polyps, type 2 being adenomatous polyp, type 3 being invasive cancer. So this will help us to assess the polyps when you do the polypectomy. Now I will go over several studies since 2020 that supports the cold snare is ideal for all kind of polyps, especially which is not too greater in size, like when it is less than 3 centimeter, but it can be used as good as hard EMR. So first of all, I will talk about the systemic review and meta-analysis in 2020 and 2024. The 2 authors, they published that cold snare polypectomy is very ideal for sessile-situated polyps, especially sessile-situated polyps of any size greater than 10 millimeters, no matter of size in sessile-situated polyps, with a very low recurrence rate, that's 0.9% if you can see it, look at 2020, and 3.1% if you look at the 2024 study. So this supports the sessile-situated polyps can be removed with the cold snare, no matter of size. This is a randomized controlled trial published in 2022 by Rex group from the United States of America, where they did a study in the polyp size of 6 to 15 millimeter. And in this size of the polyp, they found that the cold snare technique was 100% effective followed by the cold EMR, and then heart snare, then heart EMR. With very low recurrence rate in cold snare polypectomy, you can see, if you look at it, it's 0%, the recurrence rate with the cold snare polypectomy, cold EMR 1.2%, but slightly higher with heart snare polypectomy and heart EMR. Now, the secondary outcomes of that study was, of course, the resection times was way faster in cold snare polypectomy because you don't have to connect the pad and we don't have to connect the electrosurgical units. But on block resection was high with the heart EMR. And intra-procedural bleeding was high with the heart EMR. So the procedure adverse effect was low with the cold EMR, and it was fastest, which is ideal for the size of 6 to 15 millimeter. Now another study from little bit greater polyp size from the previous studies, 10 to 19 millimeter. They did they didn't compare with the heart EMR, but they did with all polyps with the cold EMR, and they found that the recurrence was 1.7%. With the incomplete resection was just 2%. It means that the technical success was very high and the recurrence was low, with the polyp size of 10 to 19 millimeter, favoring cold EMR again. This is another trial, randomized controlled trial, published in 2024 by O'Sullivan Group from Australia, and they studied the polyp size between 15 millimeter to 5 centimeters. So the polyp size was very high. The polyp size was greater than the prior studies. However, the recurrence was very high. If you take a look at this on the right side, there was 18.4% with the cold EMR, but just 1.1% with the heart EMR group. But the recurrence was higher in the polyp size greater than 3 centimeters. So greater than 3 centimeters, it was equally effective, either cold EMR or heart EMR. Now, this is again another randomized controlled trial comparing cold versus heart snare. And this is a German chronicle trial published in 2024. They did the study in 363 patients with 396 polyps, and the size of the polyp was 3 centimeter plus minus 1.02 centimeter. And majority of the polyp was on the right side, and majority of the polyp was tubular adenomas. So they found that the cold snare EMR group had a high recurrence rate when the polyp size was more than 4 centimeter. But the recurrence rate was similar when they considered the polyp size between 20 to 29 millimeter. And again, the striking point was that the polyp, sessile situated polyp, there was no difference in the recurrence rate in the both arm, like in the cold or heart EMR. So again, the sessile situated polyp is very, very ideal, no matter of size. Now, this is a recent randomized controlled trial published. It was not published, actually, it was abstract in DGW in 2024, yet to publish as a full length. So this was a trial and they included very high number of patients, 660 patients and 714 polyps, and all the polyps were more than 2 centimeter. Again, same result. The recurrence was very high with the adenomatous polyp, and more high in the high-grade dysplasia polyp with the tubular adenoma, 46%, almost 46%. But when they considered sessile-situated polyps, either cold or heart, you can see the 15% recurrence in cold and 14.5% recurrent in cold when it was sessile-situated polyp, no matter of size. This is, I'll just touch upon one more study, which is meta-analysis of the randomized controlled trials published in 2024. Similar result, high recurrence rate with the cold EMR with the tubular adenomas, and as compared to the heart EMR, but the adverse effect was very low in cold EMR. So favoring that, if the polyp size is considerable, like up to 3 centimeter, even its adenomas, there is a similar result with the cold snare versus heart EMR, but with a very low risk of adverse effect. So what are the key factors that favors recurrence rate with the cold EMR in the tubular adenomas? One could be like superficial depth of resection, because with the cold EMR, hardly we go below the muscularis mucosa. And submucosa, if the tubular adenoma is like big in size, it can be involving it with submucosa. So that could be the one reason the recurrence rate could be high if the size of the polyp tubular adenoma is high. Other could be like if the endoscopist may not be able to take the entire margin of the during the taking the cold EMR during the cold EMR process, resulting into higher recurrence rate. Third reason could be the piecemeal resections. When the cold EMR was performed, probably because, and during the piecemeal fashion, the island of the tissue, island of the polyp may have been left behind because of a little bit of bleeding during the procedures, leading to recurrence. So these are the hypotheses. These are the the principles behind recurrence rate in the cold EMR, especially in the adenomatous group. So what are the implementations in the resource limited settings with the heart EMR versus cold EMR? So the challenges of the heart EMR is that there may be limited access to the advanced electrosurgical units in most of the countries, underdeveloped countries, and like in Southeast Asia, in our countries like Nepal. And there may be higher costs associated with the electrocartridge device and maintenance and additional training required to perform the heart EMR. So these are the challenges. What are the advantages of the cold snare polypectomy and cold EMR? So there are a lot of advantages. As the number one is there is no need of electrocartridge equipments, reducing the cost, lower complication rates, minimizing the need for advanced medical interventions. And when the patients are on uninterrupted anticoagulation medications and higher comorbidities, very poor surgical candidates, no matter what the size of the adenoma is, it's better to do the cold EMR rather than heart EMR because of the comorbid conditions and other conditions which I discussed before. So that's one advantage. So what are the takeaway points? So the takeaway points from this talk is that if the polyp size is less than 10 millimeter, so invariably resect to the cold snare. And also when the polyp you consider is the sessile situated polyps, then no matter of size, it can be safely and successfully resected using the cold snare polypectomy or cold EMR. Up to 10 millimeter, there is no questions about cold EMR, even in the adenomatous polyps, but 10 to 29 millimeters, there are a lot of studies and data now since 2020 which supports that cold EMR is as good as heart EMR in terms of recurrence and in terms of technical success. After 3 centimeter and beyond, there may be challenges to perform the cold EMR where heart EMR has superior upper hand because of the less recurrence rate. So, but we know that majority of the polyps are small and medium size, and most of the time it can be done with the cold EMR, and sometimes we might have to refer for the heart EMR if there is challenges during the procedures and during the complexity of the polypectomy. So with this, I would like to thank our organizing committee for giving me the opportunity. I'm really glad to present today in front of all of you. Thank you very much.
Thank you, Dr. Amrendra, for your excellent presentation. We will have questions at the end of the session. Now, I would like to invite our next speaker, Dr. Divas Khadka, consultant gastroenterologist at Bir Hospital. He will be talking on prucalopride for constipation. Over to you, Dr. Divas.
Good morning, everyone. At the outset, I'd like to thank all the delegates, speakers, and chairpersons for being part of this update and making it a huge success. Slides, please. So in next 8 to 10 minutes, I'll be talking about prucalopride, which has been recently launched in Nepal. So constipation is one of the most common digestive complaints in general population. Its prevalence is in the tune of dyspepsia. Around 15 to 20% of the general population suffers from chronic constipation. So quick review of types of constipation. It is usually classified as primary constipation when the gastrointestinal tract is normal. Other is secondary constipation when it is usually because of the drugs or some organic disorder, and next is the irritable bowel syndrome associated constipation, where pain can be a predominant feature. So this was a study done among patients with chronic constipation under treatment, and they looked at the efficacy of the treatment, whether they were taking fiber or over-the-counter laxatives or prescription laxatives. Majority, more than 50% of them were not satisfied. They had ineffective relief of constipation, lack of predictability, ineffective relief of bloating. So moving on to prucalopride, it is an agent that stimulates colonic motility, selectively binds to serotonin receptor in myenteric plexus of GI tract, specifically to 5-HT4 type. It was FDA approved in 2018. We previously had serotonin agonists like tegaserot and cisapride, but they had low affinity, poor selectivity for 5-HT4 receptor, poor efficacy, and had some serious side effects, so they were withdrawn from the market. So what is the mechanism of action? It is a serotonin agonist. More than 90% of serotonin receptors are found in intestine, mainly in enterochromaffin cells. They are also found in epithelial cells and neurons in the gut wall. So binding of serotonin to the receptor causes activation of intrinsic neurons, and that causes release of acetylcholine. So the release of acetylcholine will ultimately stimulate peristalsis. It will increase fluid content in the colon. It will decrease visceral hypersensitivity, alongside promotion of longitudinal smooth muscle contractility. So this cartoon depicts the mechanism of action. I want you to focus on the left part. You can see there's a serotonin receptor in epithelial cells. When the prucalopride is attached to the receptor in the epithelial cells, it causes increase in intestinal fluid secretion. Next is the activation of neurons within the gut wall will cause release of acetylcholine within the muscularis propria, leading to contraction of smooth muscle. That will ultimately cause initiation of peristaltic reflex in the form of high amplitude propagatory contraction. So what is the indication? It is primarily indicated for adults with chronic idiopathic constipation, and majority of the guidelines have recommended its use in whom laxatives have failed to provide adequate relief. So let's move on to the dose. So it is recommended at the dose of 2 mg once a day. It can be taken with or without food, can be taken at any time of the day. And for elderly population more than 65 years of age, we should start at 1 mg once a day and increase if required. For patients with hepatic impairment, for mild to moderate impairment, no dose modification is recommended. For severe, better to start at 1 mg. For renal impairment, for mild to moderate, no dose modification is advised. For severe, 1 mg once a day should be started. So it is usually excreted unchanged. Majority of around 60 to 65% of it is excreted in urine unchanged, and 5% is excreted in feces. So let's look at a few trials. This came out in 2008 in New England Journal of Medicine, where they compared prucalopride with placebo in patients with severe chronic constipation who were not responding to conventional treatment. So we can see around 30% of the patients responded to prucalopride compared to 10% among placebo group, and the p-value was highly significant. This was a study that came out from Asia Pacific region, from China. Here also, the prucalopride group, 33% responded to the treatment compared to 10% in placebo group, and the p-value was significant. This came out from India in 2023, from Odisha. Here they compared 90 patients in placebo group compared to 90% in prucalopride group. The response rate was around 40% compared to placebo, which was around 12%, with a significant p-value. So what are the contraindications of prucalopride? Hypersensitivity to active substance, the prucalopride or any of the excipients in the tablet is the contraindication. Renal impairment requiring dialysis, intestinal perforation or obstruction due to structural disorder of the gut wall is a contraindication, and obstructive ileus and severe inflammatory conditions like severe Crohn's disease or ulcerative colitis are also contraindication. In pregnant and breastfeeding ladies, it is not recommended. So what are the adverse effects? Headache is a common adverse effect occurring in around 20% of the patients. Abdominal pain was seen in around 14% of the patient, followed by nausea and diarrhea. So these adverse events usually start within few days of therapy, and they tend to improve with continued use. So how long should we treat with prucalopride? So majority of the trials done in constipation, the treatment has been given for at least for 12 weeks. So recommended that treatment should be reviewed at 3-monthly interval. and it is desirable to consider a period of without treatment after 6 months of continued use. So let's review the recent guideline from AZA on management of chronic idiopathic constipation. So it starts with ruling out alarm features. So for patients with alarm features, we should always go for additional testing like endoscopic evaluation, imaging, or other lab tests to rule out if we are dealing with some organic lesion. So if there are no alarm features, the first recommendation is to increase the fiber in diet. If there is unsatisfactory response, then we can move on to osmotic laxatives like polyethylene glycol, magnesium oxide, or lactulose. So what to do if there is unsatisfactory response? So usually when we treat patients with constipation, we should treat them for at least 12 weeks before we say that, okay, the patient is not responding properly. So if there is unsatisfactory response despite the use of previously mentioned treatment, so we can either consider stimulant laxatives as a rescue, or this is an important part, we should consider evaluation of pelvic floor dysfunction, because studies have shown that as 25% of the patients with chronic constipation are suffering from defecatory disorder, and the management of defecatory disorder is not drugs, but it's biofeedback therapy. So if unsatisfactory response is there, we can either switch or add other prescription medication like secretagogues, but these are unfortunately not available in Nepal. So we can go to prucalopride. So this is the last slide. So what is the take-home message? So before moving on to drug therapy, we should ideally optimize non-pharmacological approach to increase diet, to increase fluid content. A significant proportion of patients with chronic constipation have inadequate relief with currently available treatment. So at least 50% of the patients being treated with conventional treatment are not satisfied with the drug that we're giving. So we must rule out dyssynergic defecation. So prucalopride can be helpful in patients who are not responding to conventional treatment. So coming to price, the cost of 2 milligram of prucalopride is around 65 Nepalese rupees, and we should also look out for the common adverse events. So thank you all, and I'll leave with this, the final slide, where I introduce you to a new society, Crohn's and Colitis Nepal. So this is a non-profit organization that is dedicated towards research, advocacy, and education on inflammatory bowel disease, where the physicians involved in taking care of patients with inflammatory bowel disease are coming together. I kindly request you to join this organization. Thank you all for your patient hearing.
Thank you, Dr. Divas, and congratulations and best wishes for your new society. Now we have, let us go to the next speaker, the difficult colonoscopy. Dr. Bodun Shrestha, he is a consultant gastroenterologist from Chiton, Bharatpur.
Good afternoon, respected professor, dear colleague. At the outset, I'd like to thank the organizing committee for this opportunity provided to me. Today, I'm going to talk about difficult colonoscope. Basically, we are talking about, I'll be talking about the diagnostic difficulties in diagnostic colonoscope. I'm sure you must sitting here have been doing colonoscope, and you must have faced different kind of like difficulties in doing the colonoscope. So what is difficult colonoscope? We might be having difficulties in performing the diagnostic colonoscope, and then we might be having a different type of difficulties in performing the therapeutic colonoscope. So as an endoscopist, if we have trouble in getting through the entire colon and we fail to do so, we call it a difficult colonoscope, and it is challenging for both endoscopist and then patient as well. So ACG and ASG recommends 90% of cecal intubation and 95% for screening colonoscopies. So in your practice, I'm sure you must be having different kind of difficulties, and then the factors what we usually encounter during the colonoscope is poor bowel preparation. So there are different kind of bowel preparation score, and I'm sure before doing very difficult to negotiate up to the cecum. Sometimes, like the anatomy, sometimes the colon could be tortuous, redundant colon, and if the patient has got diverticular disease, that also creates a lot of difficulties in performing the colonoscope, especially if patient has a bigger diverticulosis. Like we might get confused the lumen with the diverticulum. So sometimes any pelvic surgery like a hysterectomy or even the mini lap surgery for tubectomy, this can also cause a problem in the colonoscopy. If there is any stricture, either luminal stricture or if there's any intraluminal growth, that would cause like problem in performing colonoscopy, in the sense like somebody who has stricture or intraluminal growth, it's really difficult for them to prepare the bowel. Body habitus, for example, if somebody has got low BMI or somebody is really obese, in that situation also we might be getting a problem during the colonoscope. And especially when we talk about the gender, in the female patient, it is a little bit difficult for us to perform the colonoscope because they have a longer colon, and then they have a lot of twists and turns in the small, like abdominal cavity as their BMI is low. So the female gender, it's one of the cause for difficult colonoscope. And age, if we consider the age, younger patient, sometimes we really have difficulty in performing the colonoscope because the younger patient, they might have a lot of pain, they have a tighter mesentery, and then as we know, the patient gets older, the mesentery becomes more lax and more elastic, so it's easier to perform the colonoscope as the age grows older. And when we talk about the pain, I think if we do colonoscope with proper sedation, I think that can be taken, that can be like overcome. Sometime even when we perform the colonoscope as a colonoscopist or endoscopist, even we have like a poor endoscopic techniques. Unless we have good endoscopic technique or colonoscopic technique, it is really difficult to negotiate sometime in the sharp turns, especially when there is a like turn between the rectum and sigmoid, a turn between the sigmoid and the descending colon, and sometimes even in the hepatic flexure, right? Procedure wise, when we perform the procedure wise, I think rectosigmoid junction and then junction of sigmoid and descending colon is difficult, especially in the younger and slender patient. Hepatic flexure, we have difficulty in negotiating to the ascending colon, especially in the tall and obese patient. So how do we like overcome the difficult colonoscopies? We have different techniques. When we perform the colonoscope, we would like to minimize the looping. Looping meaning like when we push the colonoscope, there might be like a loop inside the peritoneum, inside the lumen, abdominal cavity. So we try to minimize the looping with the frequent, like less insufflation and then frequent pulling back and trying to placate the colon over the tube, minimal insufflation, adequate sedation, obviously with IV anesthesia. If you have that, patient complains, the patient may have less pain. And then if there's a redundant colon, I think adult colonoscope with a stiffer colonoscope, it's easier for us to negotiate through the turn. Tight turns, if there's a tight turns, sometime pediatric colonoscope or slim colonoscope can be useful. And then if there is abdominal wall hernia, I think I'm sure all of you would like to examine the patient before you perform the colonoscope. If there's any abdominal wall hernia, you might be reducing. We might be reducing the like large hernia before we perform the procedure. And sometime if there is large hernia, I think we need to have adequate counter pressure, abdominal pressure, and generous position change. I'm sure all of you must be practicing this. Usually, sometime if I have difficulty, we start the colonoscope in the left lateral position, and if we have difficulty in negotiating in the hepatic flexure, usually I turn the patient to the supine position. So sometime, like if you have difficulty in negotiating through the sigmoid colon, sigmoid turn, you might be giving us abdominal pressure. So another technique is sometime, like if you use the fluoroscope would help you to find out, it's a real-time X-ray. It would help you to find out the position of tip, and then if there's any loop inside the abdominal cavity, you can deloop it or you can reduce the loop. So fluoroscopic guided colonoscope can be useful sometime to find out the pathology as well as find out the position of your tip of the scope, and then if there's any loop you can find it out easily with the fluoroscope. Now while performing colonoscope, if there is a problem negotiating in hepatic flexure, I think especially in the tall and obese patient, we might be using a slender colonoscope. Sometime we need sometime to make the colonoscope stiffer, we can use a guide wire to make a colonoscope stiffer. If there is any stricture, I think stricture we got to be careful. There might be a stricture because of the interluminal growth, or sometimes there might be like a stricture in the muscular layer of the colon. So in that we can downsize the size of scope using the pediatric scope or gastroscope, or sometime we can even use a balloon dilator, especially when we deal with the stricture. If the scope is not negotiating, you wouldn't like to push it very hard. If you try to push it hard, there's a chance of perforation. So either you dilate the stricture before you push the scope, or you might be using a slimmer scope like a pediatric scope or gastroscope. Now using the gastroscope, as we all know, gastroscope is a shorter, and then so when we use gastroscope, it might be difficult for us to reach up to the cecum, because sometimes like we might get lost in the sigmoid colon, as the sigmoid is sometimes longer. Now in post-surgical patient, especially those patients who has undergone pelvic surgery, sometimes it's really difficult for us to negotiate in the sharp turns. In those cases, what we do is we often try to pull back and try to placate the colon over the tube, trying to make colon as straight as possible. We might be giving abdominal pressure. So sometimes pressure in the left iliac fossa, or sometimes pressure in the right upper quadrant, that might be helpful to come over the sharp turns. And then sometimes even we try to inflate, we try to give a lot of air to find out the lumen. So that might also cause difficulty in negotiating the sigmoid. So you would like to decompress sigmoid volvulus if it is there. Now, while we perform the colonoscope, the one problem we encounter is sometimes, perforation. So far in my practice, I've caused one perforation. Usually, a tip is not the part of the scope that causes the perforation. Usually, there is the shaft of the scope. When we try to overcome the sharp turn, and we are not sure, where the tip is heading, and then we try to push the scope harder, and then without even knowing, the shaft of the tube might cause a tear in the sharp turns, and then even you can proceed that without with the perforation also you can proceed, and then you can reach the cecum. You might not even noticing the perforation unless the patient complains a very sharp pain, and then difficult pain. And when we come back, when we examine the colon, when we come back, even you might miss the tear caused by the shaft of the scope. So to prevent the perforation, we got to make sure we don't push against the resistance. We try to pull back often and pull out the loop. We try to placate the colon, the movable part of the colon, as far as possible to prevent the perforation. Now, even in my practice, sometime I have used gastroscope to complete the colonoscope where there is, difficulty, and then there's a stricture. So there are few, trials where ultra thin colonoscope is being used. There are few randomized control trial comparing pediatric colonoscope with the adult colonoscope. Pediatric colonoscope obviously has shown the better result, 97% versus 92 cecal intubation. Stricture where pediatric colonoscope could not be negotiated, ultra thin colonoscope can traverse the stricture if usefulness of pediatric colonoscope or colonoscope is in the adults. Now, sometime we can use a rigid tube over the scope. It can be rigid or flexible depending upon the application of the vacuum. There was a retrospective study of case series in 12 patients which showed the over tube to assist the difficult colonoscope, and the cecum was reached in almost all the cases. Sometime balloon assisted colonoscope it especially, you know, like help in shorten the bowel loop. Now, there are a few abdomen compressing devices. So, sometime, you know, like apart from, you know, like applying the manual pressure, sometime we can use a collar wrap. I'm sorry, the video is not working. So in this video, there was a, you know, like a collar wrap being used, and then the colonoscope being performed. Sometime, you know, like apart from the manual abdominal pressure, we can use this collar wrap. Sometime we can. We already have discussed about the stiffening wire. Stiffening wire. There was a randomized control trial with no any difference in the cecal intubation. So it is not feasible for us to sometime, you know, like perform complete colonoscope, especially in those patient, in the older patient, in those patient who has a stricture, or in those patient who complains a lot of pain. Usually in my practice, I don't push the scope very hard because I have faced per person once. I don't want to do it again. So I try for, you know, like to overcome any sharp turns. I try to overcome it for 5 or, you know, like 6 minutes. If I cannot, I just abandon the procedure. And then in the failed colonoscope, what option we have? We have, you know, like different options. Like, as you all know, we have CT colonography or virtual colonoscopy. As you all know, we also can perform capsule endoscope. The only disadvantage is, you know, like sometime if there's any lesion, we cannot do the biopsy with these CT colonography or capsule endoscope. But, you know, like at least you can make out the location or lesion, and then you can make a diagnosis and you can proceed further. So this is a, you know, like you all know capsule endoscope, how we perform, how we prepare the bowel, how we let the patient swallow the capsule, and how the capsule, you know, like takes the picture. So with this, you know, like I think this is my last slide. So we must all have faced the difficult colonoscope in our practice. So there are different techniques, different, you know, like things we can do. If you have any experiences of, you know, like a colonoscope, if you have any your suggestion, I would like to, you know, like welcome. I'd like to discuss it. Thank you for your patience listening.
Thank you, Dr. Borun, for your wonderful talk. We would like to move on to the next topic. So our speaker for the next topic is Dr. Bhuvaneshwar Yadav, consultant gastroenterologist at Kosi Hospital, Viratnagar. You will be talking on quality indicators for colonoscopy. Dr. Bhuvan, please.
And good afternoon, everyone. And at the outset, I would like to thank the organizing committee for giving me this opportunity. And I will be talking about the quality indicators of the colonoscopy. Colonoscopy is one of the common procedure we do in our day-to-day practice. And it is the procedure which is highly operator dependent. And there have been a lot of cases of this inconsistent performance regarding this colonoscopy. And because of this inconsistent performance, this, especially the American College of Gastroenterology and American Society of Gastroenterology, they gave the guideline about this quality indicators of colonoscopy, which was first given in 2006, and later it was updated in 2010, and the latest guideline was given in the 2024. And basically, my presentation will be focused around the latest guideline of 2024. Now, hopefully at the end of my presentation, we will be able to take home message some important points regarding the day-to-day practices, so that we can tune our day-to-day practices regarding this colonoscopy and increase the diagnostic yield as well as have better satisfaction for the patient. So why should we care about the quality? The reason being is that it makes us effective in the sense of detecting the colorectal carcinoma and reducing the chances of this colorectal carcinoma. Also, it makes us safe. It reduces the complication of the patient, as well as it is tied to the reimbursement, especially the physical quality reporting system and high value practices. And it also leads to the patient satisfaction. So you see when you see the graph, we want to be at the right top upper quadrant. Now, it is said that the colonoscopy has drastically reduces the chances of this colorectal carcinoma, and it has also reduced the incidence of this colorectal carcinoma. It is said that the incidence has been decreased by nearly 31%, and similarly the mortality related to colorectal carcinoma has been reduced by 50%. So, although the colonoscopy is very effective tool in reducing the incidence as well as the mortality, it is not 100% perfect. So, there is always the room for improvement, and by this improving the quality of this colonoscopy, we can increase its efficacy as well as quality. So, whenever we talk about this colorectal carcinoma, one of the important things that we need to talk about is the interval cancer. So, interval cancer means these are the cancers which were initially not detected at the time of this first screening colonoscopy, and later on at the time of the second this screening colonoscopy, these are the cancers which are detected. And it is, the studies have shown that the incidence of this interval carcinoma ranges from about 7 to 9%. And mostly these interval carcinomas are found in the proximal colon. So what are the reasons for this interval carcinoma is that it has been postulated that the reason for this interval carcinoma is mostly the missed polyp, another being the incompleted resected polyps and rapid progression of the new polyps and inaccurate pathology of the present colorectal carcinoma. And out of these two, the missed polyp and the incompleted resected polyp, it accounts for the nearly 50 to 75% of the cases of this interval carcinoma. And by improving the quality of this colonoscopy, we can reduce these chances of the interval carcinoma, and there will be less chances of this colorectal carcinoma. So what are the quality indicators? The quality indicators that has been given are basically divided into three parts. That is the pre-procedures, intra-procedures, and post-procedures. The pre-procedures quality indicators are the frequency with which the colonoscopy is performed, rate of adequate bowel preparation. Similarly, intra-procedures are cerebral intubation rate, detection indicators, and resection indicators. And post-procedures are appropriate screening and surveillance of the intervals and proportion of the serious adverse event. I will not be able to cover all these quality indicators. However, I will be talking about some of the quality indicators which are very useful in our day-to-day practice. Now, the first important thing is that appropriate indications of the colonoscopy. The data has shown that nearly 20 to 50% cases of the colonoscopy are inappropriate. So, if you perform the colonoscopy for the appropriate indication, definitely the yield is going to be high. What the studies have shown that the cases of the appropriate colonoscopy, the diagnostic yield is approximately around 40%. However, in cases of this inappropriate colonoscopy, the diagnostic yield is markedly reduced. It is around only 4%. Now, this is one of the landmark study which shows that when the appropriate indications are, colonoscopy is done for appropriate indications, it is the yield of diagnostic yield is around 37.58%. And when it is done for the inappropriate indication, the yield is only about 4.7%. So you can nearly about, the yield is nearly 9 to 10 times higher if you do the colonoscopy for the appropriate indications. Now, another important thing is the rate of bowel preparation adequacy. If the bowel preparation is adequate, the chances of finding the polyps or lesions is very high. There are different markers or the scales for the quality of bowel preparation, but the most commonly used marker is this bowel preparation scale is Boston bowel preparation, and it is said that the total colonoscopy score of this Boston bowel preparation should be greater than 6, or for each segment it should be equal or greater than 2. And the guidelines which we follow for the screening should be only followed if the bowel preparation is adequate. If the bowel preparation is not adequate, that surveillance interest should be decreased. It is said that the inadequately prepared bowel, or if there is inadequately prepared bowel, then you can repeat the colonoscopy within 1 year. And here also we can see that as this quality of bowel preparation is high, the chances of detecting the lesion is very high. Whereas you can see here, the quality of bowel preparation, when the quality of bowel preparation for each segment is around Boston bowel preparation score of 2 to 3, it is the chances of detection of polyp is comparatively higher compared to the quality of bowel preparation of 0 to 1. Now, another is a cecal intubation rate. It is also known as the colonoscopy completion rate. And it is said that when the cecal intubation rate is high, the chances of detecting the lesion is high, and the chances of interval cancer as well as the chances of this colorectal carcinoma are also less. So, what is the adequate cecal intubation? It is said that we should be able to visualize the appendicular orifice, and we should be able to visualize the mucosa which is between the appendicular orifice and between the medial wall of the ileocecal valve. And that should be clearly photographed and shown in this colonoscopy report. Now, this that is cecal intubation rate or completion rate and intercorporal carcinoma, are they related? And there has been a lot of study, and this is one of the landmark study which has shown that if the cecal intubation rate is high, there will be less chances of this having interval cancer. And what this study has shown, that compared to the cecal intubation rate of 80 to 84%, when the cecal intubation rate is more than 90 or it is around the 95%, you can see that the odds ratio is less compared to this 80%. So the chances of having the interval cancer will be less. So if you can just do the proper cecal intubation rate, that will again decrease the chances of this having the interval cancers. Now this is one of the most important quality marker, which is the adenoma detection rate, and it is defined as the total number of colonoscopy which were done for total number of colonoscopy where at least one adenoma is found by total number of colonoscopy performed by gastroenterology in a given time period. And if there is high adenoma detection rate, then the quality will be high and there will be few missed chances of having the cancers. And the now recommendation is that threshold of this 35% is kept for this adenoma detection rate, and 40% in men and 30% in women. Previously it was 25%. And now the question arises, is adenoma detection rate associated with interval cancer? And this was answered by two large studies. The first one, this was done in Poland, and where they included nearly 45,000 of these patients, and they compared the adenoma detection rate greater than 20% with the adenoma detection rate of less than 20%. And what they found is that the chances of having interval cancer in cases of this adenoma detection rate, when it is less than 10%, is high compared to the adenoma detection rate of greater than 20%. And clearly you can see in this graph, when the adenoma detection rate is less than 20%, there will be less chances of having the interval colorectal cancer. And when there is adenoma detection, when the adenoma detection rate was that is less than 20%, there were more chances of having this colorectal cancer. Now this is again another study. Here also we can see that as the highest adenoma detection rate was associated with the lowest interval colorectal cancer, and 1% increase in adenoma detection rate was associated with 3 to 6% reduction in the interval cancer. Now again, this also here we can see that is the odds ratio of this hazard ratio of having the interval cancer was higher when the adenoma detection rate was less. We can see that when it was less than 20%, there was 1.74%, and when it was greater than 32%, it is around 1. So as the adenoma detection rate is higher, there is less chances of interval colorectal cancers. So there are certain limitations of this adenoma detection rate also. So what are the limitations is that they are difficult to track and measure. It is a non-static, and taking an average over a longer duration time may be erroneous. And two threshold of this adenoma detection rate is not known and can be sometimes misleading. So I will give an example here. For example, there are two gastroenterologists who perform 10 colonoscopy, and you can see that the first gastroenterologist, he finds one adenoma in cases of out of this one adenoma in the 5 cases, and he does not find the adenoma in the next 5 cases. So for this gastroenterologist, the adenoma detection rate is around 50%. Now you see the next gastroenterologist, what he also does the same 10 colonoscopy, and he finds 5 adenoma in the first colonoscopy, and he doesn't find any adenoma in the next 9 this colonoscopy. So here you can see that for the second gastroenterologist, the adenoma detection rate is only 10%. However, if suppose the 5 out of the 5 adenomas, some are the high-grade adenoma, which might progress to this colorectal carcinoma. So though this gastroenterologist has the adenoma detection rate of less than 10%, he might be successful in preventing the colorectal cancer compared to the first gastroenterologist. So it can be misleading or erroneous multiple times. Now another thing is the withdrawal time. So regarding withdrawal time, it has been said that the withdrawal time should be equal or greater than 8 minutes. Now the latest guidelines, initially it was 6 minutes. It has been said that only the withdrawal time is not enough. It is said that the withdrawal technique should be also proper. So if you use appropriate techniques, that includes the adequate distension of the ball, washing and cleaning of the ball, and looking beyond the folds, and segmental inspection, and subjecting timing. So these are the withdrawal techniques, and if you follow the proper techniques, then you can have the highest adenoma detection rate. So there has been a study showing the withdrawal time and the detection of this adenoma, and it has been shown that the withdrawal time of 6 minutes was associated with the adenoma detection rate of 23.8%, and similarly the withdrawal time of 9 minutes was associated with the adenoma detection rate of 33.6%, and 30% increase in serrated polyp detection rate was an average increase in withdrawal time from 9 to 10 minutes. Now there has been a correlation between the withdrawal time and adenoma detection rate also. Here also we can see that in this study also we can see that the withdrawal time on the x-axis and adenoma detection rate on the y-axis. And what they found, when the straight line was drawn, there was a clear correlation between the withdrawal time and adenoma detection rate. Now here we can see that the relation between this withdrawal time and this adenoma detection rate. You can see that as the withdrawal time was less than 6 minutes, the chances of having the interval cancer was higher. However, you can see that at the 8 minutes, the chances of this, once it is 8 minutes, the chances of having the interval cancer was less. And further on increasing the withdrawal time beyond 9 to 10 minutes also, there was not much increase in the detection of adenoma detection rate. So now the latest guideline recommend the 8 minutes as the withdrawal time. Now there are certain things. Okay.
Could you wrap up, please, Dr. Bhubaneswar?
So also another thing is that we should also try to record the adverse event which occurs during the colonoscopy and try to rectify that. That is also one of the important colonoscopy indicators. And another thing is we should also counsel the patient for the appropriate follow-up or screening for the next time. That is also one of the quality indicators. So now coming to this summary, a good technique is essential and careful segmentation and inspection should be done. We should always try to look beyond the folds, and segmentation and time withdrawal should be done. At least 8 minute time should be spent during the withdrawal time, and validity quality metrics that should be tracked can be improved, especially the complication rate, adenoma detection rate, and withdrawal times. Technology can help us, but there is no substitute. Thank you.
Thank you, Dr. Bhubaneswar Yadav, for your excellent presentation. Now we'll go to the next topic. The speaker, Dr. Tsering Wangdi Serpa. He is the assistant professor in TU, IUM, TUTH. His topic is technique of endoloop polypectomy. Dr. Tsering, please.
So good morning, and to begin with, I would like to thank the organizing committee for having me here today to speak on this topic. So I'll be talking on endoloop assisted polypectomy. So as you know, the endoloop is a device that is made up of a non-conductive flexible nylon and is used to ligate the stalk of pedunculated polyps. And it was first developed by Pontecorvo and Pesce. And it was then called the safety snare, and later Hachisu, in collaboration with Olympus, developed the commercially available detachable snares called polyloops that we currently use today. So endoloops have come a long way, and this is the first ever paper published on endoloops. It was published in Endoscopy in 1986, and this innovation represents a significant step in preventing hemorrhage after transection of large pedunculated polyps. So speaking about post-polypectomy bleeding in pedunculated polyps, it can be immediate bleeding or delayed bleeding. So immediate is bleeding that occurs more than 1 minute after polypectomy, or that begins within 24 hours, and the incidence is approximately 1 to 8.5%, whereas the delayed bleeding is the one that occurs between 1 to 14 days post-polypectomy. So it can occur earlier due to sloughing of eschar or the scab that covers a vessel, and it can occur later due to increasing zone of necrosis. And we know that the zone of necrosis is produced as a result of the thermal injury during Hertzner polypectomy. So the incidence is anywhere around 1 to 4.5%. So post-polypectomy bleeding is influenced by several key factors, and the most important factor is actually the size of the polyp and the thickness of the stalk. And polyps located in the right colon, they tend to bleed more as it has more thin wall. Other factors include use of anticoagulants, older age, and comorbid conditions. And using of a pure cutting mode of electrosurgical current can lead to immediate bleeding. And of course, malignant polyps tend to bleed more as they tend to be larger and they have more blood supply. So this study that was published in gastrointestinal endoscopy evaluated the relationship between the blood supply of the polyps and the post-polypectomy bleeding, and they found that the diameter of the base of the polyp was directly proportional to the number of blood vessels, and also found that the increasing size of the polyp, increasing diameter of the polyp stalk, and malignant polyps were also some important risk factors for post-polypectomy bleeding. So the malignant pedunculated polyps consist of cancer cells that invade the submucosa through the muscularis but do not cross the submucosa, and that is regardless of the lymph node status and without distance metastasis. And the level of invasion of the stalk will dictate whether polypectomy can be done or whether we'll need more invasive surgery. So Haggett classified the level of submucosal invasion into 4 parts. So level 1 is when it only involves the head. Level 2 is involvement of the neck. Level 3 is involvement of the stalk, and then level 4 is involvement of the submucosa below the level of the stalk. So the Haggett classification is important in the sense that when we have a Haggett level for pedunculated polyp, then there is increased chance of lymph node metastasis. So up till Haggett level 3, we can get away with an polypectomy, provided we get a margin of at least 2 millimeters. However, if we have an Haggett level for polyp, then the patient will need to undergo surgery. So this is another last study from Japan, retrospective study that evaluated more than 1,000 pedunculated polyps, and they found that the stalk diameter, if it's more than 6 mm, and especially if it's more than 1 centimeter, is the most important risk factor for immediate bleeding, and also found that for polyps more than 1.5 centimeters with a stalk of more than 6 millimeters, prophylactic use of endoloops was a significant inhibiting factor for bleeding. So based on this, we've got the 2 society guidelines. So endoloops would be indicated for any polyps with a head more than 2 centimeters or a stalk more than 1 centimeter, according to the European guidelines. While according to the US guidelines, endoloops can be used for pedunculated lesions with head more than 2 centimeters or stalk thickness of more than 5 millimeters. So when not to consider an endoloop is also important. So we do not use endoloops on semi-pedunculated lesions because there is a chance of the loop being slipped. Do not use it on thin stalks because the snare loop can transect the polyp and cause immediate bleeding. And of course, application of loop to residual stocks can lead to loop slippage. So before we apply the loop or before the procedure, the most important thing is to be for both the endoscopist and the assistant to be aware of handling the loop. So the loop has four parts. So it has the preloaded loop, the plastic sheath, the yellow cylinder, and the handle or the slider. So the first thing we have to do is move the yellow cylinder away so that the loop moves inside the catheter. And then after that we put the catheter into the scope, and once we are in a good position, then we move the yellow cylinder back to open the snare in the lumen. So the loop can be opened for up to about, the diameter is about 3 centimeters, but we can adjust it by moving the yellow cylinder. And once we are around the polyp, the stalk of the polyp, then we move the handle slider back to close the loop over the polyp. And now that would be a point of no return. And then after that we have to deploy the loop by moving the handle slider away. So it's also known as the 4-step ABBA method for detachable snares. And again, these are for the Olympus scope, that is Olympus poly loops that are commonly used. So how do we apply the loop? So the first step to do is to advance the loop enclosing the catheter just beyond the polyp head and open and expose the loop fully. Then we pull back gently and position the loop over the polyp head and onto the stalk. And again, this is easier said than done because the loop is very flexible and floppy, and so it may take some time to get in position. But once we are in position, then we tighten the loop slowly and secure it around the base of the stalk. And then we observe for the change in color of the polyp head. So once it turns bluish or purplish in color, we know that we have strangulated the blood supply to the polyp head, and that is when we push the handle away to deploy the loop. So next is to snare the loop. So we close the snare in position around the stalk and hold it tight. You can ideally do it for 30 seconds as it induces physiological coagulation. Then we apply a short burst of coagulation current to coagulate any vessels, and then apply cutting current to transect the stalk. We should transect the stalk few millimeters above the endoloop because we do not want to avoid cutting the loop or causing the loop to slip. At the same time, it's again important to ensure that a sufficient length of the stalk is still attached to the poly loop, and that is to ensure a clear margin in case of an unexpected malignancy in the head of the polyp. So, so some things to be mindful about. So whenever we're dealing with a big polyp, and when we are using the monopolar circuit, the current will always travel through the narrowest area. So if we have a large polyp with a small contact to the bowel wall, then it can lead to traveling of the current through that part, leading to counter burn and perforation. So to avoid that, we have to adjust the polyp head such that there is a broader area of contact and we can make the cut in the correct position. So we can have some complications of polyctomy. Those include transection of the polyps. So if it's less than 4 mm in size, there can be slippage of the loop, and sometimes really the loop may be trapped inside the catheter and we may not be able to deploy it. And just to summarize, peduncular polyps with thick stalks pose a significant risk for post-polypectomy bleeding. Endoloops prevent post-polypectomy bleeding by severing its blood vascular supply. So while removing the polyp, we should always try to do for end block removal, and it again works very well with clips and epinephrine as well for extra safety. But we should always be more mindful while dealing with giant polyps with thick stalks and especially suspected malignant polyps. Thank you.
Thank you, Dr. Sering, for an excellent presentation. Now we'll go for the next speaker, Dr. Ravin Sharma. I think Ravin is working as a consultant gastroenterologist in Medicity Hospital. His topic is video capsule endoscopy, when and how. Dr. Ravin, please.
Good afternoon. At the outset, I'd like to thank the organizing team for the invite. So I'll be speaking on the various technical aspects and the current clinical application of video capsule endoscopy. So as we know, GI tract is pretty long. It's 30 feet or 9 meters long. Small bowel makes up about 2/3 of the entire GI tract and is subject to ulcers, bleeding, tumors, and many other pathologies. It's not possible for a standard upper and lower GI endoscopy, and it can be challenging for even an endoscopy to completely visualize the entirety of small bowel. So this led to the birth of capsule endoscopy in the first place. These two Israeli gentlemen, Gabriel Idak and Eaton Scarpa, they conceptualized the first prototype of capsule endoscopy way back in 1981. It was FDA approved in 2001. The discovery of light-emitting diodes by Suji Nakamura, for which he, in fact, won the Nobel Prize in 2014, modernized the capsules that we see and use today. So just to briefly go through what a capsule camera consists of, sorry. So it has a, I don't know if it's working. So it has an optical dome followed by a lens holder and the lens followed by the sensor. It has two silver diode batteries, and which is ultimately connected to this integrated circuit. So the light enters through the lens, hits the sensor, and the images are captured, and it is sent through the antenna to the receiver. There are various brands of capsules that you have in present day, from Israel, from Japan, from US, and one from China. So the capsules that I'm aware of that is being used in Nepal is, one is CapsoCam, which is based in California, USA, and another one is CapsuBot, which is based in China. Multiple systematic review and meta-analysis have shown that there is no difference in diagnostic yield as such between any of the major brands of capsules that we have today. So any of the capsules should do the trick, bearing few weaknesses. So how do you prepare for a capsule endoscopy? The preparation is basically the same that we do for a standard colonoscopy. And overnight, 8 to 12 hours of fasting. Then we ask the patient to administer laxatives in a split dose fashion the day before and in the morning of the testing. So the how to use a capsule endoscopy. So first of all, I'll describe CapsoCam Plus. The unique feature of this device is it has 360-degree field of view. Another unique feature is it is a standalone device. It does not need to transmit any signal to the recorder. All the images will be stored in the capsule itself. So what the patient does is the patient swallows the capsule in the beginning. The patient retrieves the capsule from the stool with the help of this magnetic wand. It has been sent to the medical personnel, and the treating gastroenterologist will view the images in the computer. CapsuBot, which is based in China, works slightly differently. The patient has to wear the jacket, and the recorder is slid into the jacket. The jacket has the inbuilt antenna. And when the patient swallows the capsule takes multiple images, thousands of images, and there is this real-time transfer of all these images to the recorder. And finally, this will be interpreted by the gastroenterologist at his desk. The advantage of this system would be that there will be real-time viewing of the images in the recorder. And the second is the patient does not need to retrieve the capsule from the stool because the capsule is disposable. Obscure GI bleeding obviously is the most common indication of capsule endoscopy in today's day and age. Obscure can be both occult and overt GI bleed. Similarly, for evaluation of iron deficiency anemia or for diagnosis and evaluation of disease activity in Crohn's, these are the most common indications for capsule endoscopy, followed by others. So, small bowel is responsible for up to 80% cases of obscure GI bleed. Most of these lesions are angiodysplasias, as you can see in the figure. Many studies have shown that a capsule endoscopy has a detection rate of around 55 to 60% in detecting the source of obscure GI bleed, especially in the small bowel. So that's a pretty good percentage. This is my one patient. He had chronic iron deficiency anemia. All the tests were negative. He finally underwent a capsule endoscopy, and it shows a bleeding ectasia in the proximal jejunum. The timing of capsule endoscopy plays a major role in the detection rate, as shown by this study and many other studies, that if you conduct the test within 24 hours, as compared to maybe after a week, the detection rate drops down dramatically. As you can see here, the detection rate is 50 to 68% in the first 24 hours, and it drops down to 16 to 22% if you conduct the test maybe after a week. So if you have a patient of obscure GI bleed, all the tests are negative, and you think that patient needs a capsule endoscopy, do it immediately. Don't wait, because there might be a condition that you might not get any lesion on the later date. What if the capsule endoscopy is not able to diagnose obscure GI bleed? The capsule endoscopy comes normal. Now, that's not a completely bad thing at all, because if a capsule endoscopy is normal in a case of obscure GI bleed, the chances of rebleeding is low in these patients, and the need for further intervention is unnecessary. So the studies have revealed that there is a low chance of rebleeding in these patients. Another important indication is Crohn's disease, basically for the diagnosis and for assessing the disease activity. So there are lots of scores like Lewis score and capsule endoscopy Crohn's disease activity index, which have been used as a tool for diagnosing and both assessing the disease activity via capsule. You can see multiple pathologies like fissuring, multiple aphthous ulcers, serpiginous ulcers, cobblestoning. These are pathological hallmark of Crohn's disease. Capsules are also useful in detecting small bowel tumors, though they constitute a very little percentage of the GI tumors. They are less sensitive in detecting small bowel tumors in the duodenum and ampulla of Vater because of the fast transit of the capsule and because of the anatomic uniqueness of the second part of duodenum. Similarly, they are also useful in diagnosing NSAID-induced enteropathy. So there are various lesions you can see, like intestinal varix, NSAID-induced enteropathy. Contraindications like intestinal strictures, small children, patients having cognitive disorders. These are contraindications for capsule endoscopy. Complications of capsule endoscopy are rare, though capsule retention can happen in 1 to 2% of many studies because of Crohn's disease or NSAID-induced drug strictures per se. An interesting article, because I have a very short time. Can an experienced or a trained endoscopy nurse, is he or she equally competent as a gastroenterologist in detecting or interpreting capsule endoscopy, and studies have shown that the detection rate is quite high, 93% as compared to a gastroenterologist. Now, it's not practiced universally, but there are some centers where the nurses pre-look the images, select few slides which are abnormal. The gastroenterologist can have a look and sign off the reports. So this is not practiced universally, but it can be done. Finally, this is my last slide. This is the next frontier, I guess. Research is ongoing where they want to build a capsule which can have robotic arms and legs, which can stop anywhere in the GI tract, wherever they like, take biopsy, perform coagulation or tamponade, or even deliver drugs. So many of these projects are named as MACE or NEMO, and this by far may be the most and the best minimally invasive way to detect and treat lesions of the elusive small bowel. Thank you.
Thank you, Dr. Roshan. Now, Dr. Robin, now let us go to the question and sessions, and if anyone has any questions to the speakers. Any questions? So we'll request the speakers to come up, and as we close the session.
Thank you, speakers, for this informative session. Now I would like to request all the speakers and chairperson of this session to come on stage. I request Chairperson Dr. Sashi Sharma to provide the certificate and token of love to Dr. Divas Khadka. Now I would like to request Chairperson Dr. Bhavesh Thapa to provide with token of love and certificate to Dr. Barun Shrestha and Dr. Bhuvaneswar Yadav. Now I would like to request Dr. Bikal Gimire to provide token of love and certificate to Dr. Chiring Wangdi Serpa and Dr. Robin Sharma.
Thank you all the speakers and chairpersons. Now we move on to the next session, that is the endoscopic video competition session. To chair the session, I request the chairperson, Dr. Umid Shrestha, Dr. Yuvraj Sharma, and Dr. Bikram Pradhan. And meanwhile, I would like to request everyone to manage their time for lunch accordingly. And I essentially request all the speakers to finish their talks within the stipulated time, as we are having short of time.
सधैँ जज गर्ने अब त भाइले भाइ जहिले पनि जज फर्स्ट 6 मिनटमा अनि सेकेन्डमा चाहिँ 7 मिनटमा 7 मिनटमा त दिइरहेको छ त्यहाँ गर्छ
Hello. So welcome to this interesting endoscopic video competition session. So there are 10 competitors and each will be given 7 minutes to present their case. The first bell will ring at 6 minutes. The final bell will ring at 7 minutes. So I would like to request all the presenters to please try and complete your presentation on time. So for the first presentation, I would like to invite Dr. Mohan Bhushal, and he will be presenting on a case of recurrent anemia.
Thank you, Chairperson. At the outset, I would like to thank Bir Gastro Update team for providing this opportunity. Today, I am presenting a case of gastric polyp, who presenting as a case of recurrent anemia. Coming to brief history, she is a 65 years old female who presented to my clinic with history of shortness of breath, fatigue, and breathlessness and exertion, and she has history of patches of black stool since 4 to 5 years. She presented to my clinic on 1.5 years back with similar symptoms. She has history of multiple clinic visit and hospital visit, where she has undergone multiple blood transfusion, around 40 pins in 5 years. So this is a video of a similar patient, video endoscopy, where you can see the large polyp of around 15 centimeter in length and 4 centimeter in breadth. This is polyp we can see at the enteropyloric region. This is polyp is so large that it extends from the enteropyloric region to D1. So she presented to me with similar symptoms, so I did endoscopy and found this. And at the top of the polyp there is a large ulcer. So this is the culprit lesion which leads to anemia. So after I doing endoscopy, I planned for polypectomy. After taking a written informed consent, polypectomy was a plan. And initially sclerotic agent was given at the base, and after that I applied the endoloop at 10 centimeter from the base. And so piecemeal polypectomy was done initially at the 10 centimeter from the base, and second endoloop was applied 5 centimeter from the base. And again second additional polypectomy was done at 5 centimeter from the base, and at last again polypectomy, additional polypectomy was done after applying sclerotherapy at the base. So we can see how I applied the endoloop and how I did the polypectomy. This is how I apply the endoloop. It took me around 20 minutes to apply the first endoloop, which I applied at 10 centimeter from the base, and at I did the additional polypectomy. And again after that second endoloop was applied 5 centimeter from the base. So again additional polypectomy was done at 2 times. And last at the base, after giving the sclerosing agent, additional polypectomy was done.
This is the application of first endo loop. So after applying this endo loop, the artisanal polypectomy was done. This is the second video after polypectomy. After doing 3 artisanal polypectomy, we can see the base which after the in-block polypectomy, and hemostasis was obtained applying the multiple endoclip. And the patient, I did a repeat endoscopy after 24 hours, and there was multiple endoclip with in situ without any sign of bleeding. And after 7 days, repeat endoscopy was done. We saw the multiple endoclip with healing ulcers. And patient was followed for a period of 1 month. And at the 1 month, a repeat endoscopy was done, which showed the only healing ulcer without endoclip. So we can see the base of the polyp after polypectomy. So finally, how I managed was that I applied the 2 endo loop and do the artisanal piecemeal polypectomy, and hemostasis was obtained after application of 3 endo clip. Thank you.
Thank you very much for your nice effort. So, the questions are not allowed, I guess. Okay, thank you.
Thank you, sir.
The next speaker is Dr. Kamal Lamichhane, who is going to speak on underwater EMR of rectal polyp. Dr. Kamal.
Good afternoon, everyone. Today I'll be presenting a case of underwater EMR that was done in Department of Gastroenterology, NAMS. It was done in a rectal polyp, and I'll start with the lateral spreading tumor. And lateral spreading tumor was the term coined initially in 2005 to describe the flat lesions. Flat and sessile lesions which measure more than 10 mm in size, and these lateral spreading tumors should be classified into granular and non-granular one, and in granular one also it is further divided into homogeneous and mixed and elevated and pseudo-depressed. Now coming to the case, we have the 42-year-old male who presented with a history of altered bowel habit and had undergone colonoscopy. And we see this lateral spreading tumor measuring around 15 mm in size, and it was 8 centimeters reached to the anal bulge. At first we located the lesion and we sucked out the air located in the rectum, and then we infused the water. And after installation of the water, we can see the lesion has it has become prominent, and then we applied snare, and we catch the lesion with the snare, and then with the twisting and cramping motion, after stabilizing the polyp, we applied electrocautery, and we excised the lesion with this underwater EMR, and here we have applied the electrocautery. And we have rechecked the site of the resection to look for any bleeding and to look for any residual polyps. Here we can see with no any bleeding or any residual polyps. So we are collecting the resected polyp with a basket. Here we have collected the sample and we have sent it for histopathological examination. Now we will be comparing the conventional EMR with the underwater EMR. The conventional EMR is the well-accepted treatment approach for the laterally spreading tumors. And while using conventional EMR, we used to inject saline, normal saline in the submucosal plane. And this infused saline has certain limitations or demerits. This injection can lead to back bleeding, which can make us difficult in approaching the lesion while doing EMR. Similarly, there is theoretical chance of seeding the neoplastic cells deep into the tissue while doing conventional EMR. Similarly, while differentiating between these two techniques, the benefits of infusing water in the lumen of the colon helps to separate the lesion located in the mucosa apart from the underlying muscularis propria. Thus, it decreases the chance of having injury to the deeper tissues. Thank you.
Okay, thank you, Dr. Kumud. And now next speaker will be Susan Chandra Paudel. Oh, Kumud Bhattarai, okay. Now we watch the video of Dr. Kamal. So next speaker will be Kumud. He will be talking on use of Foley's catheter in self-dilatation of refractory benign esophageal stricture.
Good afternoon, everyone, ladies and gentlemen. My topic is self-dilation of refractory benign esophageal stricture with Foley's catheter. And coming to the brief history, she was a 20 years old female from eastern Nepal. She had a history of corrosive ingestion around 9 months back. And when upper GI endoscopy was done, there was initially a negotiable stricture at around 19 centimeters and non-negotiable stricture at enteropyloric region. So patient later had developed symptoms of gastric outlet obstruction, so she underwent gastroenterostomy for the same. She had, after a few days, she developed progressive dysphagia to solid, mostly solid, and repeat upper GI endoscopic around 7 weeks post-ingestion. It showed non-negotiable stricture at 19 centimeters.
Play your video first.
And it's coming. And Barim's swallow showed narrowing at the upper esophagus. And patient underwent a series of salivary gland dilatation with 8 mm initially and subsequently to 14 mm. And 5 sessions were done, that was done every 2 weeks. And diagnosis of refractory esophageal stricture was made. It was not dilated with the salivary gland dilatation, so steroid injection was done in the stricture and redilatation of stricture was performed for 3 sessions. However, adequate diameter of lumen was not maintained. So these are the endoscopic image of corrosive strictures with the guide wire in situ, you can see. So the different guidelines as SEG 2022 has different modalities for managing the refractory stricture, including steroid injection, mitomycin C injection, incisional therapy, stenting, and self-dilatation with boogie, and the surgical anastomosis being the last option. So we planned for the self-based home retrograde dilatation of benign esophageal stricture with Foley catheter. We arranged all the Foley set with 5 ml syringe, xylocaine jelly, and we prepared the patient. So that we can see the patient, she is inserting the Foley's catheter into the esophagus. First we showed the patient by ourselves, then patient was told to do it by herself. She's slowly inserting the Foley catheter 14 French into the, from the nostril into the esophagus. And when the entire end of the Foley was inserted, the patient is now inflating the balloon with water.
Kumud,
Initially, we...
Kumud, please look at the screen. I think the speed is not matching.
Patient is inserting the Foley by herself from the nostril into the esophagus. And whole of the length of the Foley is being inserted. Now patient is inflating the balloon of the Foley with distilled water. We initially started with 5 ml of distilled water, and later patient was told to increase the size, and now the patient is also inflating with only ear also. Now the patient is dilating the stricture with retrograde pulling of the Foley's catheter, and we can see the point of resistance, and we can see the giveaway of resistance, that is in the upper neck. And now the patient is deflating the Foley catheter balloon by herself. Post-Foley effect, the patient has been performing this Foley catheterization 1 or 2 times in a week, and she has gained around 4.5 kg weight in 4 months period, and she has been swallowing semi-solid to solid food without any difficulties, and the dysphagia score is 1 to 2. Initially it was 4. So self-dilatation of stricture is a safe, effective and cost-efficient treatment option for appropriate and selected patients with refractory benign esophageal strictures as corrosive stricture. So the pictures and videos were taken with patient consent, and I would like to acknowledge our seniors from the Eastern Nepal for wonderful series of stricture dilatation and steroid injection. Thank you.
Thank you, Dr. Kumud. So the next presenter is Dr. Sujan Chandra Paudel, and he will be talking on SEMS placement in esophagus.
Good afternoon, everyone. Firstly, I'd like to thank the organizing committee for this opportunity. So today I'm going to discuss the case of CA esophagus where we had a SEMS placement. So this is a case of 79 years old male who presented with dysphagia for 2 months, initially with solid, then liquid, associated with decreased appetite and weight loss. So initial patient has a history of hypertension and old ischemic CVA, and on evaluation, patient had a low BMI with pallor present and systemic examination normal with presence of anemia. Endoscopy showed the ulcerative growth in the lower thoracic esophagus starting from 32 centimeter up to 40 centimeter involving the GE junction, and it was suggestive of malignancy, and histopathology was sent. CT was done, which also showed locally advanced, and biopsy showed squamous cell carcinoma. So final diagnosis of locally advanced squamous cell carcinoma was made involving the GE junction. Patient has a poor performance status, so surgery was not considered, and patient was advised for SEMS placement. So this is a video endoscopic finding of the esophageal lesion starting from 32 centimeter, and there was a stricture at around 35 centimeter, and below the lesion was involving up to the GE junction. So this is a setup for SEMS placement with fluoroscopic, endoscopic, and other anesthetic assistance. So initial first step was the marking using the fluoroscopic and endoscopic guidance. So you can see the markers being used in the external markers, and this is a fluoroscopic view where there is a marker at upper, lower, and the middle part of the stricture. The initial step is to pass a guide wire through an endoscope, and then endoscope is exchanged over the guide wire. Then we put an uncovered metallic stent of size 12 centimeter, considering the length of the stricture was 8 centimeter, and 20 mm diameter of the stent was used. Then we positioned with the lower end of the stent just below the GE junction, which was checked by the fluoroscopic view, and stent was deployed again using the endoscopic fluoroscopy, and this is an endoscopic view where you can see the upper end of the stent being deployed. This is a lumen after stenting. Then for fixation, we used a hemoclip at the upper border of the stent, which was 3 centimeter from the upper end of stricture, as the stricture was at the GE junction, so we thought fixing would be a better choice in this condition also. So this is a final fluoroscopic view of stent deployment. So this is a team involved. So this is a CA esophagus involving the GE junction. So ideally anti-reflux valve will be a choice, but considering it's not available, conventional SEMS can also be placed, and post SEMS placement after 1 month, patient is relatively doing well. So this is all I have to say. Thank you.
Thank you, Dr. Susan, for your nice video. Now our next speaker is Dr. Ajay Yadav, who is going to present an interesting endoscopic video on use of plastic biliary stents for the management of colorectal varicose bleeding. Dr. Ajay, please.
Extrahepatic portal vein obstruction refers to the obstruction of the extrahepatic portal vein without involvement of the intrahepatic branches, and that involves. So, and a portal biliopathy refers to the changes in the biliary tract that may be the extrahepatic or the bile duct, and in this case, the diagnosis of the colorectal varices in the ESPBO requires high clinical suspicion. It may result in the severe clinical consequences. So, there may be biliary compression resulting into jaundice, or sometimes the colorectal varices may bleed, leading to life-threatening bleeding. So this is a 28-year-old lady who has a history of recurring pain in upper and mid-abdomen, fluctuating jaundice, and 1 episode of hematemesis. Esophagogastroduodenoscopy revealed large esophageal varices, for which bile ligation was done, and she was continued beta blocker. MRCP and CCT scan revealed ESPBO with obstructive biliopathy and the biliary strictures. So this is a video demonstrating the removal of the prior stent which was placed using the snare. At this time we can see there is no bleeding. But however, during the reinsertion of a scope for the stent exchange, we can see while we are going inside, we see the blood was coming out from the pylorus into the antrum, and when we enter the duodenum, as we can see in the next, as we can see, there is a spurting of blood. So on view of the background history of the ESBO, evidence of the portal hypertension and the portal biliopathy, a diagnosis of choledochal varicose bleed was made, and this bleeding was so severe, so there was so much blood loss, and so the plan was made to deploy or place a stent to biliary plastic stents for the management of this bleed. So first we flush this with the sterile water, then we prepared for the placement of the 2 biliary plastic stents. So this is the preparation for the placement of the biliary plastic stent. This is the first plastic stent is being placed, but still, as we can see, the active spot cannot be appreciated, but still there is some oozing of blood we can see here. Now the second plastic stent is being placed. Still some oozing of blood can be seen, but after when the two biliary stent plastic stents are placed, after sometimes we can see the hemostasis was achieved. So this patient, while the biliary plastic stenting may be a temporary measure to control the choledochal vessel bleed. However, the portosystemic shunt surgery is a definitive therapy. So in this case, we did the proximal splenorenal shunt surgery followed by splenectomy. So take home message is the diagnosis of the choledochal varicose bleeding ESPBO requires high clinical suspicion, typical cholangiogram appraisals and collateral balance circulation in imaging. And the choledochal varicose bleeding can be life-threatening when there is a delay in diagnosis and the management of the choledochal varicose bleeding. So take home message is the early identification of the choledochal varicose bleeding and the utmost addressing those choledochal varicose bleeding using the stenting that may be a plastic stent or maybe the SIMS. Thank you.
Thank you, Dr. Ajay. Nice presentation. Next speaker will be Shivam Chaurasia. He will be showing video to us EMR of gastric intramucosal carcinoma.
Hello. Good afternoon, respected seniors, teachers, and my dear colleagues. So I am Dr. Shivam Chaurasia, and I am going to be presenting a case that we did of EMR of gastric intramucosal carcinoma. In this video, you can appreciate directly video nahi play bhayo. So this is a 62-year-old gentleman who was under surveillance endoscopy for intestinal metaplasia with high-grade dysplasia. Along with, he also had a prepyloric polyp with high-grade dysplasia, which was diagnosed 2 years ago. So in this surveillance endoscopy, the patient underwent the endoscopy in which we observed a 5 mm area of showing irregularity. We used Olympus scope with enhanced imaging for this, and in this video you can appreciate the vascular pattern as well as the irregular vascular pattern as well as the surface pattern, along with line of demarcation, which in the subsequent video it will be more clear. So based on this, we took the biopsy from the suspected site, and so this is the line of demarcation shown along with the area of this is the image of the histopathology that showed infiltrating glands infiltrating the lamina propria without the invasion of the submucosa. Based on this biopsy report, then we plan to do band ligation EMR for this patient. Initially, the lesion was marked with a soft quack. Then after that, a suction was applied to create a pseudo polyp, and then hot snare EMR was done to resect the polyp. So this is the video showing the creation of pseudo polyp by application of band. So after the band was placed, then again we went to do the hot snaring for the lesion. So the snare was applied below the band and it was resected using hot snaring. I'll be also showing the post-EMR histopathological slides also, which showed only scar tissue without any residual disease or any residual lesion in the post-biopsy. And the patient is still under surveillance and is doing fine without any complaints. The patient initially had no any other GI complaints or any other significant clinical or laboratory abnormalities. So this is the hot snaring that we did. And post-resection, there was no any active bleeding or any evidence of residual lesion that was left. So this is the post-EMR histopathology, which showed only scar tissue without any residual disease activity. So I would like to thank my mentors and seniors, and also Dr. Boisali and team for providing me the histopathological slides, and Dr. Neeraj for guiding me through the procedure. So thank you.
Thank you. Dr. Ajay. Now next presentation is by Dr. Dr. Sabin Raj Bhandari. Dr. Sabin, he will present on a case of endoscopic ampulectomy, curative therapy for ampullary adenoma.
Good afternoon, everyone. Today, I will be presenting on endoscopic ampulectomy, curative therapy for ampullary adenoma. So my case is 74 years old female, resident of Udaipur, known case of hypertension and medication. She presented with epigastric pain and vomiting for 5 days. Ultrasound showed dilated CBD and ISBI. On endoscopy ultrasound, a well-defined hypoechoic lesion was seen, arising from ampulla, 2 centimeters in diameter. Biopsy was taken. On histopathology, it showed lower grade tubulopilus adenoma. Now, brief introduction of ampullary adenoma. Neoplasia of ampullary of Bader is a rare disease. Incidence less than 1 per lakh per year. Benign neoplasm of ampulla is more rare, less than 10% of ampullary neoplasms. Adenoma is the most common benign lesion of ampulla. It has potential to undergo malignant transformation to ampullary carcinoma. Approximately 15 to 60% harbor small foci of adenocarcinoma. They are mostly asymptomatic and detected incidentally, but they can present with jaundice, pain, pancreatitis, cholangitis, and CVD stones. So here I am presenting few recommendations of ESC. ESC recommends against diagnostic and therapeutic papillectomy when adenoma not proven. It recommends endoscopic papillectomy in ampullary adenoma without intraductal extension. It recommends in-block resection of ampullary adenoma up to 20 to 30 centimeter in diameter to achieve RO resection. It recommends direct snare resection without soft mucosal injection for endoscopic papillectomy, and it also recommends prophylactic pancreatic stent placement to reduce the risk of pancreatitis after endoscopic papillectomy. So my video has started. So with the help of side view endoscopy, we located the ampullary adenoma, and with the help of monofilament diathermy snare, we are trying to catch the lesion. So after catching the lesion, into cut mode, we are trying to cut the adenoma. So we did hot snare ampullectomy. Okay, the lesion is removed, and we remove the lesion with the help of Dormier basket and send it for histopathology examination. There was no bleed, so we didn't do anything to secure the bleeding. The cut margins were clean. So now, prevent the post-ampulectomy pancreatitis, we are trying to put pancreatic duct stent. So here we are doing sphincterotomy and putting guide wire in the pancreatic duct. And finally, we stated the pancreatic duct with 5 frames into 5 centimeter pancreatic duct, pancreatic stent. Finally, PD stent was placed. Thank you, sir.
Thank you, Dr. Sabin, for your very nice video. Now the next speaker is Dr. Swarup Shrestha. He is going to show his video on catch the culprit early, timely detection of C. difficile in ulcerative colitis.
Good afternoon, everyone. I'm Dr. Swarup Shrestha. I'm here to present you a case of a 38-year-old male who was diagnosed as a case of ulcerative colitis 6 months back. And he was maintaining remission with 5 ASA, 3.6 grams per day, until he had an acute flare 7 days back, where he presented with 6 to 7 bloody stools per day, and he fulfilled all the 2 Lowitz criteria of the severe ulcerative colitis. So he was diagnosed as a case of acute severe ulcerative colitis and was started on IV steroid and heparin. And all the blood investigations were sent, and the stool was sent for routine culture and C. diff investigations. And on the 3rd day, the patient was not improving. As a part of a routine investigation, we did the sigmoidoscopy on the 3rd day of admission. When we did the sigmoidoscopy, we could see the previously diagnosed ulcerative colitis, which with the features of erythema, edema, inflammation, and a few superficial ulcers. So we graded it as myoendoscopic subscore of 3 and endoscopy UCEIS score of 5 out of 10. Then and while we were doing the colonoscopy, we also saw some yellow and off-white plaques and some pseudomembrane-like appearing tissues loosely attached to the surface of the colon. But since we know that pseudomembrane is not a regular feature of Clostridioides difficile infection, and it's not exclusively seen in C. diff infection. And we also know that C. diff, pseudomembranous colitis, pseudomembranes are very rare in cases of IBD. So this is the picture we are used to seeing of pseudomembranous colitis in non-IBD patients, where we see yellow or off-white plaques of variable sizes ranging from few millimeter to up to 2 centimeter, loosely attached or often firmly attached to the colonic wall, which may progress as the severity increases, and as it gets fulminant, then it may cover whole of the mucosal surface like a paste. But this was not the case in our case. So since we suspected the C. difficile infection, and as a part of routine investigation, we took the biopsies from the plaques and from rectum and sigmoid colon for the to find out if there is any infections. The usual infectious cause of acute severe ulcerative colitis comprises around infection comprises around 10% of the ASUC, and C. diff comprises around 50% of the total infections. We sent the sample for histopathology, and our pathology friends came with this mushroom or volcanocyte eruptions with ischemic mucosal surface and a debris mucin and pus exudates, which is more suggestive of ulcerative colitis. Ulcerative colitis superimposed with Clostridium difficile infection. This type of findings can sometimes be also seen in other forms of infection, like CM infection, or sometimes even in ischemic colitis. So what the challenge is that the presentation of active IBD or C. diff infections are pretty similar and very confusing. The usual presentation of C. diff may be ranging from erythema, edema, inflammations, erosions, and sometimes pseudomembranes. But the peculiar feature of C. diff infection in IBD, which differs from the other non-IBD populations, that it usually occurs in the young age, as opposed to the elderly persons who are more infected in non-IBD patients. the females are more infected in non-IBD patients, and C. diff infection usually occurs with a history of use of culprit antibiotics, long-term use of proton pump inhibitors, or long-term residence in the healthcare settings. These may not be the case of C. diff infection in IBD, as was our case where the patient was younger and he had no history of recent antibiotic use or no history of hospital visits in the last 2 months. So it must be a community acquisition of the disease. And since pseudomembranes are rarely seen in IBD, there's always doubt when we see a typical colonoscopic picture whether it's a feature of active IBD or it's a C. diff infection. So the other challenge is that people with IBD are at least 5 times more prone to get C. diff infection than the ones who don't have IBD. Pause, Basa. So if we have searchful eyes and high index of suspicion in cases of IBD, even if it's a rare occurrence in IBD, the pseudomembranes can be pretty evident when we do the examination more carefully.
So your time is off. Thank you very much for presentation.
Thank you.
So I'll be calling next speaker, Dr. Vigyan. He will be talking on EMR in colonic polyp.
So good afternoon, everyone. First of all, I would like to thank Gastro Update organizing team for providing me opportunity to present on the case. So we have done the endoscopic mucosal resection on the colonic polyp in Chiton Medical College, which I am going to present now. So our case is a 71-year male from a Dhanusa, known case of hypertension on amlodipine, past alcohol consumer and reformed smoker, presented with a complaint of rectal bleed for 6 months. Intermittent episodes, painless, bright red in color associated with passage of scanty, hard stool, and no urgency or tenesmus. We kept the possibilities of colorectal malignancy, diverticular bleed, hemorrhoidal bleed, inflammatory bowel disease, and vascular angiodysplasia. On colonoscopy, we found a sessile polyp of Genet 2B pattern in the proximal descending colon of size 1.5 into 1.5 centimeter. As per ESG recommendation for colonic polyp, sessile colonic polyp of size less than 20 and rectal polyp less than 25, we prefer hot snare polypectomy. Now under this, we injected submucosal solution with a normal saline and a methylene blue as an dye over the edge of the polyp to create a submucosal cushion, such that the polyp along with its mucosa, it will get raised and get separate from the underlying muscularis propria. Then we'll catch hold with a snare and we jiggle to get the entire margin of the polyp. And following that, we perform the hot snare electrocoagulation and cutting. Following the procedure, we can notice that there was an intra-procedural bleed For that, the ESC guideline recommends either mechanical therapy with or without a combined use of dilute adrenaline injection for intraprocedural bleed. And accordingly, we underwent with endoscopic hemoclipping, where we, with the help of claw, we hold the edges of the lesion, and we applied the endo clip. And subsequently, we applied 3 more endoscopic hemoclip sequentially in a zipper fashion for achieving the hemostasis. So these are the steps that we performed for a hot snare polypectomy. And on the resected sample, we can see there was the irregular vascular pattern leading to the Zenit 2B pattern. So post-EMR, there was no fall in hemoglobin, no porictal bleed, and patient was discharged in hemodynamically stable state after 24 hours. On the follow-up colonoscopy, we can see the healed up lesion at the site of polypectomy. And so I would like to conclude my video with that EMR is safe and effective for treatment of sessile colorectal polyp of size less than 20. Complication can occur during and after procedure, which can be managed by endoscopic methods. Thank you.
Thank you, Dr. Bigyan. So last presenter of this session is Dr. Milan Shrestha, and he will be presenting on intraoperative enteroscopy.
Thank you, Chairpersons. Firstly, I'd like to thank the organizing committee for providing this opportunity. Today, I'm going to present on intraoperative endoscopy. It is a case presentation, 24-year-old male, non-smoker, non-alcoholic, with a history of recurrent painless over GI bleed for 2 years in the form of melena with occasional hematochezia, with history of more than 100 units of blood transfused, with hemoglobin of minimum 3.2 during his presentation. Multiple upper and lower GI endoscopy was done, which was normal. Along with push endoscopy, we did not reveal any pathology. CT and angiography was done, which showed normal report. During multiple visits, he had undergone deep endoscopy for 4 times, all revealing a normal scan. Video endoscopy done showed proximal jejunal bleeding, which was likely secondary to AB malformation, following which a deep endoscopy was attempted, but no pathology could be found. So, considering his young age, we planned for the definitive treatment. So, we contacted our surgical counterpart for intraoperative endoscopy. Now, for any suspected small bowel bleeding, whether overt or what, first, if usual endoscopy is done, we can recheck the endoscopy. If it's still negative, we should pursue the evaluation of small bowel evaluation, CT and CT interrography or BC can be used initially to identify the lesion, following which deep bowel endoscopy can be done. And in cases where patient has normal scans during even deep endoscopy, the surgical counterpart can be contacted for intraoperative endoscopy. For the patients under the age of 40, inflammable bowel disease, dilapidal lesion, neoplasia, macroscopic and polyposis are the major causes. Over age, angiotasia, dilapidal neoplasia, and NSH also are the major causes. Rare causes like blue bars can be present. As per ECG, intraoperative endoscopy is the most reliable method to achieve a complete small bowel evaluation, but it is highly invasive. It should be reserved only for those patients who have the history of recurrent bleed requiring multiple transfusion or hospitalization after a comprehensive workup with BC and deep endoscopy. For patients in whom deep endoscopy cannot be performed without lysis of the adhesions, as per ECG guideline 2015. Now, here we can see the surgical counterpart creating a port for endoscope insertion, which was done at 60 centimeters from the ICU valve. Initially, retrograde evaluation of colon was done, which was uneventful. Then the antegrade evaluation was done, which showed a streak of blood along the jejunal fold. The remaining area of the small bowel was evaluated, which did not show any significant finding due to the presence of discrete lesion over the proximal jejunum. The lesion was marked and planned for surgical intervention in form of dissection and side-to-side anastomosis. In this patient, here we can see the flow of blood and the jejunum. The remaining areas of the jejunum seems to be normal with no mucosal abnormalities. Now regarding the case, the bowel 15 cm proximal and distal to the breathing side was surgically resected with side-to-side anastomosis. In this patient with double layer suturing, surgery plays an excellent role in discrete lesions such as AB malformation or tumors. As per ECG guideline 2015, the sample was sent for biopsy, which revealed angiodysplasia in this patient. Following surgery, the patient has been doing well, and his recent hemoglobin is 8.2, and no fresh bleeding has been documented after the surgical intervention. Thank you.
Thank you, Dr. Milan. So I think that ends the session. Thank you, everybody, for the speakers and audience. That it's closed now, the session. Thank you.
Thank you all the chairpersons and the presenters of the wonderful video presentation. The winners of the presentation will be awarded at the end of today's event. Meanwhile, hands-on training for hot smear polypectomy is also being conducted by Dr. Jivan Thapa and Dr. Bhavesh Thapa. Interested participants can join the hands-on training. The timing is from 1:30 to 2:30.
Now we move on to the next session, that is the debate session. To chair this session, I would like to request the chairpersons, Dr. Sarat Pokhrel, Dr. Bidanidhi Paudel, Dr. Nirajan Subedi, Dr. Rahul Pathak, to chair this session.
Thank you. So now we have an interesting schedule now. We have a debate. So we still have some time. So we'll wait for 30 minutes and then start the debate.
There has been a slight change in the schedule. We'll have a 10 minutes lunch break and then we'll resume our session.